I warmly welcome you all to this free live webinar on Autism Spectrum Disorder. To create an awareness as this month, April, being an International Autism Awareness Month declared by United Nations Organization UNO. Now I would like to introduce the moderator for this webinar, Dr. A. Jagadish, Senior Consultant Newborn and Pediatric Early Interventionist in Neurodevelopmental Disabilities. He is a master trainer in autism tools, INDT, ASD, and ISA, and master trainer in early intervention for neurodevelopmental disabilities. And he is a member of Neurodevelopmental Pediatrics Chapter, Indian Academy of Pediatrics, IAP, member of Indian Academy of Cerebral Palsy, IACP, and also member of Indian Child Abuse, Neglect, and Child Labor, Eye Cancer of Indian Academy of Pediatrics, IAP. He is also a double gold medalist from Osmania in the year 2001. Currently, he is a visiting consultant to Department of Pediatrics, Apollo Institute of Medical Sciences and Research, Apollo Health City, Jubilee Hills, Hyderabad, and HOD Department of Pediatrics Early Intervention Unit, Krishna Children's Hospital, Hyderabad. His areas of interest are childhood autism ASD, ADHD, that is Attention Deficit Hyperactive Disorder, SLD, Specific Learning Disabilities, Intellectual Disabilities, Cerebral Palsy, Neuromuscular Disorders, Speech, Language and Communication Therapeutics, Genetic Counseling, Common Early Childhood Orthopedic, Neurological Conditions, and their Early Therapeutic Interventional Program, and also Childhood and Adolescent Psychological Issues. He is expertised in assessment, planning, and early intervention in intrauterine growth retardation child at risk, high risk, and disabled children in 0 to 3 years age group. He has also presented several papers and posters in regional, national, and international conferences. Now, I welcome Dr. Jagadish sir to moderate for the session. Thank you. Over to Dr. Jagadish.
Thank you, Monisha, for the introduction. The main purpose of this free live webinar is to create an awareness among the parents, therapists, pediatricians, and other medical professionals, as the incidence or prevalence of autism spectrum disorder is increasing year by year. The worldwide prevalence is almost 1 to 2%. In India, 13 million individuals are suffering with autism spectrum disorder. Hence, there is a need to conduct this kind of webinars and seminars and conferences to create an awareness among the general public. Why? Because the autism is becoming one of the epidemic globally and nationally. In this webinar, we are going to cover various important topics like screening of autism, diagnosis of autism, surveillance in clinical practice, and some issues related with adults with autism, and the role of genetics in autism, and very important evidence-based intervention programs in autism spectrum disorder, etc. And we are conducting this webinar in association with Indian Academy of Pediatrics, TCB. I would like to introduce the first speaker of this live webinar, Dr. Leena Srivastava. And she is a developmental pediatrician and neurologist and head of the Department of Child Development and Guidance Center, Bharati Vidyapit Medical College and Hospital, Pune. And also she is a consultant at Cloud9 Hospital, Pune, Maharashtra. And she is a guide, coordinator, developmental behavioral pediatrics fellowship program at Bharati Vidyapit Medical College and Hospital. And she is a joint national coordinator of IAP module on neurodevelopmental disorders. And she is having experience of working with children for more than 20 years. And she was the National Secretary, Indian Academy of Pediatrics chapter of Neurodevelopmental Pediatrics 2018 to 2019. And she worked with almost 8,000 children with neurodevelopmental disorders. And she's a faculty at national, regional conferences on topics like neurodevelopmental disorders like autism spectrum disorder, attention deficit and hyperactivity disorder, and learning disabilities, speech communication disorders, cerebral palsy, early intervention, parenting, and behavioral problems in children. I welcome you, Dr. Leena. Now, over to you. Thank you very much.
Thank you, Dr. Jagadish. I welcome you all to this webinar, and I will now start with a very basic and a simple topic that I think something that will sensitize us to the beginning of autism spectrum disorder. And since we have a mixed crowd, I am sure it will be a little basic for a few of you, but then we need to start from there. We'll basically be trying to try to correlate our theoretical knowledge with how we can apply it and use it to try and spot the early signs or the red flags very early in the child's life. Okay, I am from Pune, and I know a lot of my colleagues and interventionists from Pune are also in this webinar. Nice to catch up with so many people at once. So let's talk about the early signs of autism. And for those who are, want to start from the basics, we know that autism spectrum disorder is a neurodevelopmental disorder. We know that it has impairment in social communication and interaction and restricted and repetitive patterns of behavior. But what I want to emphasize is that each child with ASD is still unique. And many a times, or most of the times rather, no two children behave alike. This is due to the broad range of symptoms and the variation of presentation in each child. So this is what we should remember when we see the children. Now, we know it is common. We know that most studies say it's 1 in 57 to 59 in the US. Even Indian studies are giving us, around 1% incidence. But we must remember that in spite of all this knowledge, in spite of all the coverage autism spectrum disorder is gauging, the mean age of diagnosis in most studies is still 2.7 to 6.2 years. We know that early identification and early intervention is the key to better outcomes. And yet, why are we delaying it so much? And thus, I think identifying red flags early and initiating intervention with developmentally appropriate goals is our responsibility. The responsibility of every professional working with children, be it doctors, interventionists, or other professionals. A diagnosis is not essential to start intervention, and this is something we should remember. We need not wait to an age where we can diagnose or label the child, because that is not our goal. Our goal is to spot red flags early and start intervention in the best way possible for the child. Now, let us correlate our theoretical knowledge. We know that the core clinical features are impaired social communication and interaction. But when we are speaking about this, we must remember that what I'm saying first is the non-verbal communication, then the verbal communication and social relationships. Because many a times the verbal communication sort of pitches us away from the diagnosis. So it is very important to keep the non-verbal cues also in our minds while looking at the children. And of course, the restricted and repetitive patterns of behavior, interest, and activity. But this is the theoretical part. Let us correlate it practically. We see the deficits in social communication most of the time as a limitation in their social emotional reciprocity. That the lack of intent to communicate with their peers, with their caretakers, and especially share interests. And when we are talking of sharing interests, we talk a lot about pointing and joint attention, which we will also talk about. Deficits in the non-verbal communicative behavior, that is eye gaze, facial expressions, gestures. Even as I'm talking to you spontaneously, even though I'm not on screen, we get all these things so unconsciously. We have an eye gaze, we have facial expressions, we have gesturing while we're talking. And there is a limitation of these things many a times in these children. Of course, as they grow older, we see deficits in developing, maintaining, and understanding relationships. So as you see, the presentation may vary. But when we are talking of younger children, as developmental pediatricians, we are very particular, starting very early and looking at these gesturing or sharing of attention, especially in the form of joint attention. And for many of you who don't know, joint attention is a spontaneous behavior in which all of us actually, but when we're talking of infant and toddlers, try to share interest, amusement, or anything about an object with a caretaker or playmate. As humans, we want to, show something to everybody before, we enjoy it. Like, we may purposefully look back and forth between the object of interest and the eyes of the caretaker or whoever is with us. And this a child can do as early as 8 to 10 months of age. Or then a slightly older child of 14 to 16 months of age may point to the object and look back at his mother to see if she sees what he's seeing, as we can see in that picture. Everybody wants to share it. Now again, when we are talking of pointing, we are talking of proto-declarative pointing, where the pointing is used to share interest. There is another pointing, which is proto-imperative pointing, in which we usually point to an object out of reach in order to obtain it. Like the child may want a biscuit and he may point to the object because he wants that. So we are more interested in the proto-declarative pointing when we're looking for a red flag for autism spectrum disorder. Coming to the social interaction part also, that can also have a varied presentation. There may be children who prefer to be alone. There may be children who have limited social interest. And there are others who want to socialize but don't know how to go about it. And many a times that causes a lot of humor and bullying in their peers because they're not sure about how to initiate social interaction. And it is really, really, you feel empathetic towards them because you have these children who, would go and hug the child really hard and the child would run away from them, when actually that was this child's way of showing friendship. Then coming to the language, many a times we always associate communication with language. But the presentation of language in a child of autism spectrum disorder or with autism spectrum disorder features may have varied presentation. So sometimes you may have no language at all, like the child may be nonverbal. Sometimes you may have language, but it is used very less, as in for labeling or for very, very acute needs, like the child, I want chocolate, want ice cream. Just how much he really needs, or to label, red color, red ball, right? He may use the language only like that. Or then you have those children who have a lot of language, but they may have poor pragmatics and may have a very pedantic way of keeping on speaking. We also may have echolalia, where we see these children repeat things that they have heard either on TV or what their parents have said, and many a times it is out of context. We will be having a detailed lecture on the speech and language aspect later. Now, when we are talking of restricted and repetitive behaviors or interests, mostly they're stereotype patterns of behavior, right? There may be motor stereotypes that we talk about, like the flapping or the rocking, etc. And sometimes they may be much more subtle. And also, there is a lot of resistance to change in routine. Many children will just throw a big tantrum or have a meltdown just because there is a change of their usual routine. Sensory inputs, DSM-5 has also included the hyper or hyposensitivity to sensory inputs as another feature. Now, when we are talking of sensory inputs, what are we talking about? The sensory processing abilities in all of us vary. There are many of us who have a label in the shirt and are so agitated that are unable to focus the whole day. There are others who wouldn't even, like if you ask me, I wouldn't know if my shirt has a label or not. So sensory processing is different and variable in the best of us. But in children with autism, you see that there are aberrant sensory processing abilities in about 42 to 99%. And many a times you see this dysfunction absolutely actually affect their functioning, right? A lot of hyperactivity, behavioral problems may sometimes be found to be related to the sensory dysfunction. So aberrant responses may include over-responsiveness, under-responsiveness. Like a lot of them will have sensory speaking. They would want textures to feel. They constantly want something in their hand to sort of, feel. They may, constantly want to smell something. Like you have children who, they'll roam about with the soap in their hand and would want to keep on smelling it, etc. Even if you give them a biscuit, they would first smell it and then try and eat it. So, or then they may have sensory aversion. Like a lot of them would respond to very daily noises like a vacuum cleaner or a blender or a toilet flushing and would close their ears and would not be comfortable. So these responses also affect the child's behavior and they need to be worked on. Now, many a times I think impairment in play, something not, we don't observe very usually, but I think that gives us very good clues. The play in these children is very characteristically different. toys and objects are used, but in very inflexible manners. Like they may keep on spinning, they may keep on rolling them. They prefer to play with blocks, puzzles, letters, colors, numbers, more than dolls, role plays, or more interactive play. They have very little reciprocal or turn taking. So play skills in a usual child, they use a lot of pretend play. There is a lot of imaginative play and symbolic representation. And we know that this is the key to the development of language. But then, if you see these children, the play skills in a child with autism, they may be very little symbolic, pretend play or imaginative play, and maybe a lot of repetitive play patterns like, keep on observing the wheels or keep on trying and spinning objects, etc. Sometimes, absence of interest in imitation or pretend play may be an early red flag which would want you to go deeper and see if developmentally how the child is doing. Always remember, we're speaking about a lot of red flags, but they have to be put in perspective. We're not talking of one red flag as diagnostic or indicative of autism. Remember also that all these symptoms must be present since early childhood, and secondly, they must impair or limit development or everyday functioning to some extent. Otherwise, the child may not need a diagnosis. It's very important to look into that as well. So this was all relating what the symptoms are. But in clinical practice, what would you do? You can't keep on looking at one symptom. Now, very broadly, we know that in a young child, it's the limited eye contact, the lack of joint attention or finger pointing, little interest in peers or caretakers, limited display of language or echolalia, getting upset by minor changes in routines that may be the presenting features. But in older children and adolescents, maybe because they had milder features and were not diagnosed, or they have come to you with difficulty now, even though their symptoms date back to early childhood, they may have difficulty in maintaining conversations, speaking another's point of view, initiating social interactions, reading non-verbal cues. Like if I'm face-to-face with you, I would sort of have an idea whether you're getting bored, whether I need to vary my presentation. But these children would have very little clue. And if they're talking of an aeroplane, they would keep on talking about it without wondering about whether you're liking it or not. Making and keeping friends, understanding socially appropriate behaviors. You see many of these older children, like your 5, 6-year-old children coming to my clinic for the first time and then just being over-friendly, coming and just sitting on my lap, which is not socially appropriate behavior for that age. So many a times they are unable to distinguish socially appropriate behavior. Since we've broadly seen what it looks like in a younger child or an older child, I would like to say, why even wait till then? I think very early, especially if you're working with children, very early symptoms may not be the presence of any abnormal features, but maybe the absence of normal behavior. Interacting with an 8-10-month-old child, and there's this warm, joyful, reciprocal expression. You go, do, and the child actually gurgles back at you, babbles back at you, and there is this interaction and the connect, the reciprocal connect, which sometimes is missing from these children, and you can notice it as early as that. In fact, some mothers will say that he's a very good child, very quiet, very undemanding. Even that would sometimes want me to go further and look at development in detail and see if I'm not missing anything. Also, parental concerns about inconsistent hearing, in the sense that they'll say, when I call out his name, he just doesn't respond.
When we joined audio, we got it.
Sorry? So they may say that whenever I call out to the child's name, he does not respond. But at the same time, if I put a jingle on a mobile, the child comes immediately. So many a times, inconsistent hearing or response to name also may be a sign to look for these features. Extremes of temperament. Many children, in fact, come for this extreme irritability. And they have these extremes of temperament and extremely exaggerated responses to change in routine, etc. There are some who also will have a regression of social skills and speech. Now, that may not always be indicative of autism, but maybe or maybe not. And you should look into the development in detail. And I'm sure Dr. Lokesh will be sensitizing us to some conditions which need further work. Now, all this should occur at every preventive visit, every child visit, no matter what you do when you meet children. You must also look for risk factors. Now, you have a child, your elder sibling has features about autism, you would want to worry about that. You would want to look at this child with deeper concern. If parents are concerned, please, please, please heed their concern and look into it in detail. Look at the developmental history in all the domains. Look at the head circumference, vision and hearing, definitely. And document every finding of yours, whether it is positive or it is negative. Now, when we're looking at a child, I think 3-4 very, very simple observations can sometimes be shared. A child comes into your clinic, he's 12 to 15 months old, you call the child's name, he looks at you. You ask him, where's mama? He looks at his mama and looks back at you, or he points at his mama and looks back at you. You say, oh, look at the fan. And the child looks at the fan and looks back at you joyfully. So these simple 2-3 questions will give you such a good, this one about the eye contact, about the gaze referencing, about the pointing, and evidence of joint attention. Just 2-3 quick questions when the child is walking in. But then, how do you distinguish this child of autism from other typically developing children, right? Because now a child comes at 12 months, whenever you call his name, as we said, the child will look at you. A child with ASD will sometimes not turn and look, even after several calling of names, but then he will respond to something that rings on your mobile or other sounds. At 18 months, now suppose a child with delayed speech and language skills come to you. Now again, it's a cliche. You need to differentiate that. So most of the time, whether it is hearing impairment or a child with delayed speech and language, other causes, the child will point, he will gesture, he will use a lot of facial expressions, but he will make up. In fact, he will compensate for his lack of talking. A child with ASD may make no attempt to compensate and may not even, worry, look at you, and may just be parroting something that he has heard somewhere. A child of 2 years old, you give him a picture or a toy, he'll immediately take it to his mother and share his joy with her. But a child with ASD, even if you give him a bottle of bubbles, he'll just go to his mother and even without looking at his face, will try to take her hand and, make her open the box for her, but will not share the joy of the bubbles with her. So then what do? You're looking at all these features. You want to know what to do further. If the child is below 18 months, you may not have a good screening tool, but you can evaluate clinically the social communication skills. Talk to the parents about anticipatory guidance, about play, about stimulation in their daily life, about screen time. Discuss all that with them and reschedule a follow-up. Don't be in a hurry to label it autism hai ya isko autism nahi hai. Do not hurry up to make a diagnosis in one time. You need not give a conclusion. You can observe the child another time. And if he's above 18 months, we have screening tools. We have standardized screening tools that you can use very easily. Ideally, every child should be, screened with a tool, autism-specific tool at 18 and 24 months. Now, the most commonly used tool is the MChat. The version we use now is the MChat revised with follow-up, RF. Now, this is easily available on the net with, free downloads in most Indian languages. It's used for children 16 to 30 months of age. It takes just about 10 minutes, very easy to use, simple scoring, and it gives you a low, medium, or high risk. Now, if there is a medium risk, you would call the child for a follow-up interview. If there is a low risk, you would just give them anticipatory guidance and still schedule a follow-up. And if there's a high risk, you would start intervention even without waiting for a diagnosis. So that is a very, very simple tool, easily available online and very easy scoring. You can check it out, the MChat revised with follow-up. Now, what do you do if you get a risk? Don't leave it at that. Talk to the parents, discuss the risk, discuss the options. Simultaneously, also do the basic workup of an audiology evaluation. If you feel the need, a vision check, a developmental also, when you're looking at the child, look for comorbidities, because many a times this will complicate the clinical picture, and solving 2-3 of the comorbid conditions will make the child more comfortable, and the parents will find it easier to handle for the intervention itself. So behavioral issues like hyperactivity, aggression, intellectual functioning, of course, can vary a lot in these children, and some 30% of them may even have intellectual impairment later. A lot of GI issues, especially constipation, has been seen to be there in these children more than the general population. A lot of sleep issues, definitely, and that can really be helped, and it helps the child and the family. And epilepsy can be also seen in these children, 30%. Now, my purpose of putting this slide is that we are talking about autism, and many parents will just get, focused on the diagnosis more than the child. So don't think of autism as the, whole and soul of it, and it's for autism, I can't do anything. He doesn't do this for autism. Don't use that label as an excuse, or don't use that label to underweigh or, hinder you from your real task of working on the child's development. We know that the child's development has taken a slightly atypical course, and we must do our best with good goals to get the development back as near as possible to typical development. Let us focus on that task more than the label, because many a times the label and a lot of Googling will just put the parents on a very negative track from the beginning. That is, as professionals, we have not to label or just give it a name, but help them understand that the diagnosis is only to help us understand why the child is behaving in a certain way. Now, how do we evaluate? We take a detailed history, description of the child's development. We take a lot of observations. It's the most important part. We do a general and neurological examination. We review earlier records. Hearing and vision is an absolute must. A good language evaluation and additional tests for other comorbidities, as we spoke. A good developmental assessment to tell us where he is lacking in our development, so that it helps us set goals better. And plus, of course, autism-specific tests. We know that in India, mostly we use the INCLEN tool, that is the INDT-ASD tool, which we can use from 2 years onwards. We can also use the ISA, that is the Indian Scale for Assessment of Autism, which usually now is recommended for above 6 years. It gives a mild, moderate, and severe grading to the child. Globally, of course, it is the ADI, ADOS, and the DISCO which are used. But that requires a lot of training, plus they are paid tests and need to be bought. We know that the diagnosis also can be done using the DSM-5, which by currently or by past history must meet all the criteria that we just spoke about, and also they must be present since early childhood and must limit everyday functioning. Now, when we are assessing for these children, again, I want to say vision and hearing is very important, because many of us have seen children with cortical visual impairments, etc., masquerading as autism and going on intervention for months together, and then we realize that they had another problem. So very important to do a basic vision and hearing. Also assess cognition, because then your goals will be more cognitively with focal neurological signs, etc. Assessment of a sleep disorder can help in some children. Feeding problems, especially if the child is having a lot of malnutrition. Genetic referral and testing, we have a wonderful talk by Dr. Lokesh to follow, focusing on this. Of course, metabolic testing, of course, only when indicated, and lead levels also when you're suspecting them. So when we come to the end of all this surveillance, screening, assessment, what I want you all to remember is early intervention is the key. So trying to spot the red flags and identify very early is the only thing that we can do to, give the best possible outcomes for these children. We know that there are so many features we're looking at. So obviously we need a multidisciplinary approach. Any one aspect will not solve the holistic picture of autism per se. And so you need to look at a good multidisciplinary approach with goal formulation. So when I'm talking of take-home messages, it is a single diagnostic category called as Autism Spectrum Disorder, but there is a lot of variability in severity, language, intelligence, and of course change over time of the child's age. All children have limitations in social communication, but their language may have varying difficulties. Even when language is present, there may be a lot of pragmatic difficulties like understanding a joke, sarcasm, etc., which will be covered in the talk I hope. Sensory modulation difficulties, problem behaviors, and comorbidities also should be looked for specifically, because only then will the intervention have better delivery. So to summarize, there is a red flags of autism: no babbling or pointing or other gestures by 12 months, no single words by 16 months, no two-word spontaneous, not equalalic, spontaneous phrases by 24 months, loss of language or social skills at any age. Please do specific screening for ASD in all of these children. Also, remember all that we have spoken about and look for these red flags so that we can unifiedly have early identification leading to good early intervention, which should be a multidisciplinary aspect, which we will be covering in the webinar, and hopefully better outcomes for all our children. We owe it to them to spot them early. Thank you so much for your patience here.
Thank you, ma'am. Thank you very much for your time and your presentation, which is outstanding regarding information, everything. Thank you very much.
So much.
Now
I know there was limited time, but I tried my best to make it as comprehensive.
Now I take this opportunity to introduce the next speaker, Dr.Om Ramesh. And Sir is a PhD scholar in Child and Adolescent Psychiatry and Associate Professor of Psychiatry, Department of Psychiatry, Drug De-Addiction Center, Lady Hardinge Medical College, New Delhi. And Sir, a lot of research publications actually. He has been a co-investigator and completed an ICMR project titled Molecular Genetic Study of Beta Amyloid Precursor Protein, APP, in different neurological disorders, including autism, in 2012, and has been an investigator and completed a study titled A Study on Dental Problems in Persons with Mental Retardation in 2013. Has been a co-investigator in an ongoing ICMR project titled A Multicentric RCT to assess the effectiveness of brief nursing intervention for depression in pregnancy, initiated in 2018. And Sir has many publications. The list goes on. And also there are some chapters, books co-authored, a chapter on Autism Spectrum Disorders in a book, Different Strokes, Spectrum in Psychiatry, Indian Psychiatric Society 2018. Chapter on Adolescents Belonging to Broken Families in Indian Association of Pediatrics, NPH ICP, textbook on adolescent health, and chapter on mental retardation, historical perspective and concepts, psychosocial aspects of mental retardation, and basic neurophysiology and associated condition of mental retardation for B.Ed syllabus of Madhya Pradesh Bhoj University, and Autism Spectrum Disorders, select abstract, compiled scientific abstracts in the area of autism spectrum disorder from various sources, mainly web pages, appeared during 1998 to 2003, and brought out an indexed abstract. This was released during the Indo-United States workshop on autism spectrum disorders, a challenging disability, held at Hyderabad from in the month of March 2004. Thank you very much, sir. There's a big list actually. So many publications are there, research publications. Now I welcome Dr. Om Ramesh, sir, for your presentation. Thank you, sir. Thank you very much. Go ahead, sir.
Thank you, Jagadish, for nice words. Good afternoon to everybody. And I'm very happy to be amongst you today and share some of my experiences. At the outset, I would like to thank Jagadish for giving me this opportunity. And it's a very interesting to note that, on one hand, I have Dr. Lokesh, who taught me certain basic things, such as how to look at the neurological aspects of intellectual disability way back in 2012, 2013. And on the other hand, I have two of our NIMH alumni, that is Jagadish as well as Dr. Chari, on panel. And The topic which I have chosen to talk today is depression in adolescents with autism. And we know that we are having a heterogeneous group, so therefore I will be touching upon the very basic aspects of depression in adults without going into too many neurobiological aspects. The objective of touching upon this topic is to sensitize all of us that yes, adolescents with autism spectrum disorders can also have. Many a times, the first question to most of us who comes to our mind would be that adolescent with autism spectrum disorders, whether he or she would have depression or not. So with such kind of background, I'm sharing some of my experiences. So this is how I'm going to cover my topic. I will give some introduction and then I'll talk about certain prevalence rates. Then probably my major focus would be clinical features and how to identify depression in adolescents with autism spectrum disorders and assessment diagnosis. Then I will also be mentioning some of the important risk factors which are associated with depression in autism spectrum. Then I'll be touching upon some of the management issues and challenging issues. Well, I think all of us are aware. I will not spend too much of time on these basics, like what is depression. But then, for those people, just a revision. At least 2 weeks of depressed most of the day, nearly every day, as indicated by subjective report. That is feeling sad, empty, feeling hopeless, or observed by others that the person is tearful, sad, etc. But when it comes to the children and adolescent, the depressed mood is sometimes equated with a irritable mood. It is associated with markedly diminished interest in pleasurable activities, which is seen every day, nearly every day, almost all week, and as indicated by subjective account of the. And this is associated with severe functional impairment in social, occupational, and educational settings. Now, for our surprise, it is found that depression is more common amongst teens with autism spectrum disorder than the teens without autism spectrum. Rates of depression have been reported as high as 10 to 30% in adolescents with ASD compared to those people who are in general population who may have only 5 to 10% and would. Recent studies reports that there is an increased risk of suicidal attempts amongst these teens with ASD. So therefore, this topic definitely requires our attention. Therefore, parents, teachers, clinicians, therapists needs to be aware about this, and then they should be on lookout for the signs and symptoms of depression with autism spectrum disorder when they come to the clinics. Why adolescents? Adolescence is the time when youth struggle with identity and independence. They would be trying to establish new relationships in life, and they would be more worried about how they look. They will be more worried about what they talk, how they are perceived by the others, and that is the time when one can have certain rejections, etc. And adolescents with autism spectrum disorders, at that time, they may become more aware about their deficits. For example, they will become aware about that they are looking little odd, they cannot perform like others, and they are not looking like others. They are looking little odd when compared to others. Become aware about these deficits or oddities. Therefore, the adolescent period is the very important period when you can have depression. Another important factor which we need to keep in mind is biological aspects. We all know that as the child grows, especially during the adolescence, there are a lot of changes which takes place both physically as well as neurologically as well as endocrinologically. So therefore, this particular period seems to be more, sensitive when it comes to the emotional. There's a very interesting paper which has been published in Children Journal 2008, which talks about the various aspects about depression along with the prevalence rates. And very interestingly, it has been quoted that the prevalence rates may vary between 10 to 20, 10 to 30 sometimes percentage of the population. And the difference is basically because they might have used different kinds of scales, number one. And the second important reason could be that all these scales are not specifically designed for persons with autism spectrum. They might be using some of those scales which are used in general population, or they are the specific tools which are used for some other children or adolescents with other developmental disabilities, like let us say intellectual. So therefore, the exact number of adolescents with depression is not very clearly understood, but it is understood that it is very common and it is very alarming situation that we need to help them. If we miss them, probably we will not be having quality of life in them and their family. Coming to the clinical features, what is different from other adolescents when compared to the adolescents with autism spectrum disorder? So many of our own colleagues have been asking me, like, how do you differentiate it between autism features and depression features? Because there also you will have a lot of symptoms, as not able to make friends, not able to communicate, etc. But one important thing which we need to keep in mind is that most of the symptoms which we see uh, for the depression, we call as depression, the onset should have been recent, meaning that there is a clear onset which is seen recently, and there is a sudden or insidious changes which are being noted and reported by the family members, which are different from the pre-morbid state. Meaning, if I have to give you an example, mother will come and tell you that the child was absolutely okay till 2 weeks back, and then suddenly he started remaining very silent, sad, depressed, crying, etc. So therefore, we need to try and understand whether this is a part of pre-morbid state or is it something recent. That is the most important aspect of differentiating between depression and other symptoms of autism in these adolescents. And then a lot of children, they will have positive family history of depression or mood disorders or bipolarity. So that is also needs to be kept in mind. And good number of people will also have significant stress which is being reported in the recent. That's also one important thing. And behavioral change is more important than the mood and thought symptoms. What does it mean? It means you can't go just by book, or you can't go just by ICD-10 or DSM-4 criteria very strictly. You can't have behavioral, you can't have self-reported subjective feeling of mood here. So therefore, most of the time we have to depend upon the behavioral equivalence, meaning most of the time we'll have to depend upon the family members who would report that the child is looking very sad and he cries, there's tears coming from his eyes very without any reason. These kind of behavioral equivalents are important. And it is always important to obtain an account from caretakers, family members, teachers, which is very paramount. And one thing which we need to keep in mind is that atypical presentation is common. What does this mean? It means that you can't have a very clear criteria which is fulfilling for depression as it is seen in adulthood, typically growing adolescents here. So there is a lot of atypicality, either in the form of duration, either in the form of severity, etc. And it is little difficult to categorize the depression amongst them, like mild, moderate, severe depression. You may not be able to do. However, one can try and attain this much of understanding that probably are we dealing with mild depression or severe depression. So the symptoms, if you see, they will be something like this, increased moodiness, anger outbursts, irritability, sadness, tearful, crying episode without any reason or with trivial reason, constant seeking of reassurance. This is something which is seen in our practice very often. The child will be going to the mother or father and asking, you think that I'll be okay? You think that I'll be okay? Such kind of reassurance. And they keep on asking the same question again and again. And they also would present with a lot of lack of interest in pleasurable activity, which they were doing earlier. Like, for example, we had one child who was very good at swimming, around 14, 15-year-old child. And then the presentation was that the mother was saying that for the past 3 to 4 weeks, he just doesn't like to go to the swimming pool at all. This kind of symptomatology you may see, and then it can be associated with the feeling of helplessness, hopelessness, worthlessness, suicidal ideas or thoughts or attempts. Hopelessness is something like they don't have hope. I mean, they cannot. They don't have hope about the future. They think that, okay, mommy, you can't help me. I know that. This kind of approach they would think that. And they say that I'm fit for nothing. I don't think that I'm worth matter. That kind of approaches will be there. Behaviorally, yes, there could be a lot of aggression and confusion, indecisiveness, and then there is a very noticeable decrease in the self-care. Like the child adolescent was used to take bath every day. He wouldn't take for a few days, and he wouldn't change the cloth. He wouldn't shave. This kind of behavior, which is having recent onset, is the hallmark to keep in mind. And there is a regression in previously learned skills, meaning the child was very good at calculations. The child was very good at let's say painting, etc. But currently, the child is not performing all those things. That should really help us to suspect that probably the child seems to be having different. And then you all know that children with autism spectrum disorders will be having what are called as stereotypic behavior. They will be preoccupied with certain behavioral patterns. Now, this behavior may suddenly increase in quantity or frequencies. Right? So, therefore, it is also another way of identifying. And then they can even present with hyperactivity, agitation, restlessness, and fatigability, and they may sleep too much or too little, and there can be some changes in their appetite also. They may lose weight or they may gain weight, and we have seen some adolescents coming and talking about somatic complaints so often. They keep talking about headaches, body aches, abdominal pain, without much of any evidence of pathology there. So therefore, they are preoccupied with their bodily symptoms. So what is the diagnostic approach which we as clinicians, therapists, caretakers, professionals should keep in mind? And how do we go about them? And how do we should not miss them? Or how should we not miss depression, especially adolescents with autism spectrum disorder? Something which is important is that you need to do a little more than what you do in routine professional attitude. Etiquette which you follow. Meaning you need to have little sophisticated way of looking at it. And I simply tell these important things here, which I have mentioned in this particular slide, would be sufficient. You don't have to really exercise very, very highly sophisticated things. But then, a detailed history is most starting from the onset, how the symptoms are evolving, and what are the symptoms, how are they varying on a daily course. Everything is important. So therefore, a good hearing to the parents or the family members about the history, how the symptoms are evolving, is very, very important. And I think that half of the times you can come to the diagnosis only by listening to the history itself, most of the time. Then comes the interviewing the individual. Never ever underestimate interviewing the individuals. Many people think that adolescent with autism spectrum disorders having some difficulties in communicating, etc. So therefore, there is no point in talking to them. But mind you, that can be a sort of a turning point, in fact, to help. So therefore, always give some time to them. Talk to them in privacy. Ask questions. Give time. Pause a bit, let them answer, let them look at you, let them write, let them communicate, let them indicate. That is most important according to me. And then, of course, you need to interview the parents. And most of the time, siblings can give you a very good account of what's happening to their sibling with autism spectrum disorders. And I practice another important thing in my routine clinical setup is that I'll ask the teacher to give a report. I write a letter to the teacher, and in return, they will be telling me what are their observations. Like if the child is attending some, let's say, special school, or let's say some therapies, or let's say some special classes going on. So I'll insist that their parents will get some report. And of course, we need to do serial MSCs. What is mental status examination? In fact, observe the child for a while, and you need to give time, and you need to ask questions very specific to their mood, how they are feeling, how they are getting thoughts in their mind. Sometimes they may take like little longer time to open up, but then you need to make an. And then very important is that you should avoid the subjectivity. It is better to use objective scale, such as rescale, and schedule. CBCL is the simplest tool which you can use in any clinical setup, and then probably you can elicit, if at all, if some child with autism is having any emotional. And coming to the structured, little more structured interviews, such as KSAT, that is kiddie schedule for affective disorders as well as schizophrenia. Then you also have some self-reports wherein adolescent will be able to express himself, such as children's inventory. And lastly, I'm sure all of us are practicing and using DSM-5 and ICD-10 before diagnosing a child with it. Well, there are certain risk factors which we need to keep in. And if you find these risk factors, probably there is a probability of having depression will be more, such as genetic predisposing factors, biological factors. In fact, very interestingly, I was reading one particular paper which says that adolescence seems to be the older children are more prone to have depression when compared to the younger, and girls are more prone to have depression when compared to the boys. And then there can be some history of psychiatric disorders in family, especially the suicide, etc. Substance abuse is another important thing which we come across in metros like Delhi, Hyderabad, Bangalore. These are the certain things which we need to keep in mind. And then psychological issues like somebody who is very impulsive, is having higher cognitive ability. I want everybody to note this point. What I want to highlight is that the depression is more common in those children with, adolescents with autism who are having high functioning autism. Meaning, the more you have IQ, the more you understand your your deficits, you are more prone to have depression. And then, of course, life events like frequent abuses, being beaten by family members, or sexual abuse, or physical abuse. And then very, very important chunk of people whom I see in my clinic, have been bullied in. That's another important thing which could be the reason, school bullying. And then there are so many social issues like the rejection, social isolation. The child, adolescent is not able to make friendship. He cannot have girlfriend. If it is a girl, she will not be having a boyfriend. So this can be seen as a very, very major thing by the individual or in adolescent. So therefore, this could be another important risk factors. So how to manage? There is no substitute than multidisciplinary approach. Every aspect is, as we always talk about autism disorders, it has to be a multidisciplinary. And then a lot of psychosocial interventions are being tried out. Most important is the education. You need to give them information. You need to empower them. You need to help them to tackle the situation very well at their level. Of course, medication. We will talk about this a bit because in the group we have some professionals who are prescribing the medication as pediatricians and psychiatrist. So therefore, I'll spend some time on this also. And then another important thing is that the child, whatever the other therapies which are going on, let's say occupational therapy, physiotherapy, or any sensory integration therapy, needs to be continued. There shouldn't be any sort of stoppage of all such kind of activities in view of depression. It is always better to make the child be busier than the keeping them idle. Few points about the medication. Actually, there is no medication which has been approved by FDA for usage in depression amongst the adults who are having autism. However, with a lot of clinical experience and case reports which are being confirming the positive effects of SSRI. Even in my own practice, I do use SSRIs, especially the fluoxetine, very often. And I see a lot of good results with that kind of medication. Only thing what we need to keep in mind is that we need to start it low and go slow. Meaning, you need to start with very low dose and you need to have increments which are very, very slowly high. Some of the SSRIs like fluoxetine, escitalopram, sertraline are generally tried, and I prefer fluoxetine over others. And TCAs, that is tricyclic antidepressants, are generally not indicated. So you can very well start with 10 milligrams and go up to 20 milligrams. Okay. And if you are trying with sertraline, probably 25 milligrams should be very good dose to start with, and then you can, as they tolerate. You may go up to 75 to so based on their improvement. One important thing which we need to keep in mind here is that fluoxetine seems to be, or otherwise also SSRI seems to be effective and beneficial in 2-3 ways here, because they take care of depression, no doubt about it. It is a well-tested molecule, and we have tried in adults and as well as adolescents. Typically growing adults and adolescents also, and here also. And then along with that, the symptoms of autism, that is such as, let's say, anxiety, repetitive behavior, obsessive compulsive behavior, rigidness, self-stimulatory behavior, sleep disturbances, also get improvised. So therefore, it's a good deal to choose such kind of molecule whenever it is necessary. And then small percentage of adolescents may be requiring mood stabilizers such as sodium valproate and carbamazepine, who would be presenting with, let's say, impulsivity, unexplained aggression, mood swings, episodicity, family history of bipolar disorder. Probably we may have to add mood stability. Well, I think caution needs to be exercised here about the fluoxetine, because it does have a lot of whole lot of side effects. But one thing which we need to keep in mind is that most of the times, these are initially seen, and one can, most of the adolescents will tolerate very well. But then, point to be noted here is that suicidal ideation is something which is been reported, and which is why the FDA has given black box warning to this particular one. One basic question which most of my PGs will ask me, like, when do you start this medication? I mean, when do you start any medication for that matter for depression in adolescents with autism spectrum disorder? There are 2-3 points which we can keep in mind. When you have depression which is in severe category, that is moderate to severe category, or when you have history of prior episodes, or when you have a patient who is treated for depression in the past, or we have an adolescent who is having family history of depression or any mood disorder, or when you have any family history of depression who have responded very well with the particular medication, you are choosing probably the best method of exercise. Very quickly, I'll touch upon some certain counseling tips, because majority of the times in clinical setup, we may not exercise only pharmacotherapy. Many a times we need to provide certain psychotherapy and some, psychosocial interventions too. Most important is that reassuring the child and spending time and explaining them that it is a part of depression. It is medical model needs to be explained to them, and tell them that it is okay to feel sad sometimes. Yeah, not to really feel so much like that. You need to help them, and you need to tell him that he is more stronger than the depression. I am stronger than depression. You write it to the adolescent and ask him to look at that every now and then. I tried these kind of techniques. And I also discuss certain coping strategies. In your situation, if I were there, what kind of things I would have done? I would discuss like that. Probably if I feel very lonely, if I feel like killing myself, probably I will talk to my doctor, or I'll talk to my dad, or I'll write down, or I'll talk to my teacher. This kind of explanation options can be given. And a lot of positive approach needs to be exercised. And I generally talk to them and ask them to tell about their strengths and limitations. I'll ask them to write down what are the strengths you have. I'll explain what are the kind of goals they can set in life, both short term as well as long term, and how one can look forward to achieve certain goals. By that time, probably the effect of depression will go down. I mean, these things will take place in multiple settings. It is not that in the first go itself I'll be talking about all these things. No, mostly these are the children, adolescents who would be coming to my clinic repeatedly, mostly with a gap of 15 days each time, and probably the settings will go into 6, 7, 8 sometimes. And I also try to help the child to do what is called as activity schedule. I'll ask them to divide the time accordingly, and probably they will be not having free time, so that they will be occupied. And we also have to encourage them to communicate, discuss, indicate their suicidal thoughts. Many times people think that we shouldn't be talking about this suicidality. And should we really ask this question? Are we going to give ideas to the about suicide? No. I mean, I am of the opinion that we should ask. We should definitely ask, and we should help the child to communicate to us, indicate to us, indicate to the family members. I had one child who used to, whenever he used to feel very low, whenever he had suicidal ideation, he used to write on a paper and give it to mother. He used to write there on paper that I feel like dying. This kind of things, and then probably we exercise certain intervention services so that the mother is to reach to us, and they need to seek help. I mean to say that. And a lot of things needs to be done through parents. Actually, you need to educate them. You need to help them understand what is depression, what is autism, how is it different from autism, and they'll have to be told about the salient features of depression, and they should be watchful and look out for the symptoms, especially the warning symptoms. If somebody is really handling certain sharp objects and mentioning about death wishes, one has to be careful, and they shouldn't take those things easy, and they shouldn't undermine that. And I always train the parents to build up self-esteem in their wards. I mean, I tell very simple things like, most of the time the person adolescent with depression would have low self-esteem. So I will ask them to talk about some simple settings in their house, like they are having breakfast. The mother can ask, what is the choice for you today? That kind of thing. Ask for their choice. They are buying something. Ask his opinion. And you also give responsibility to the adolescent. Somebody is coming home, so I take care of dining hall. You take care of the the main hall. Something like that. You need to make them be part of your activity and deal with them respectfully, with dignity. Many a times these things, though it looks very simple, but they do work. And you need to listen to them genuinely. Don't bluff them. Don't give them false hopes. You need to be very straightforward and then to the point. And then they should also be seeking professional help whenever they require. And they should liaison with the teachers. Most of the times parents will feel that, should I discuss this with teacher or not? That kind of confusion will be there. And teach the team to handle bullying. In my opinion, bullying is the common factor which will be the, sort of precipitating factor for depression in most of them. So they should be told how to handle, and they should be able to communicate better. They should be able to, and their body language and their communication skills needs to be told, and help them identify their emotional needs. In fact, most of the parents, I have seen that, if the child, adolescent is having depression, sometimes I find the depression even amongst the mother. So they will have a lot of burnout. So therefore, it is essential to take care of them. Suppose if you take care of them, automatically the child also will be improvised. So therefore, I work with them and I help them to avoid their burnout symptoms, and they have to distribute their responsibility amongst themselves. Like, father is there, mother is there. What can be distributed amongst them? Something like that. Especially the siblings and grandparents, they play a major role. Okay. So coming to the major challenges, I mean, just whatever we have discussed in a nutshell, there is some sort of diagnostic masking, meaning, the people will think that, I mean, the symptoms of autism as symptoms of depression, vice versa. So therefore, there is a danger that the depression is underdiagnosed or overdiagnosed. There is a overshadowing. The child is not able to communicate because of the core symptoms of autism. It will be shadowing the sometimes. And there is a difficulty in subjective self-report, because they will not say I am feeling sad. This statement they will not be able to say. There is a lack of vocabulary. So therefore, you need to help them to communicate in all ways. It could be body language, it could be writing, it could be reading. Any kind of attempt can be highly appreciated at that time. And of course, we do have very few scales which can be used with the children with autism. So that is also another challenge. And severe autism spectrum disorders with intellectual deficits will be having another set of challenges, because their daily needs itself would not be fulfilled. So therefore, if they on top of it have depression, okay, a double challenge. And SSRI sometimes can induce activation. So one needs to be kept in mind when you are giving out SSRIs, you may see some activation, meaning the child who is depressed, suddenly will become a little active, overactive, and they'll be improving very fast. It appears like. So you need to be very careful with that such kind of adolescents, because they may be the kind of adolescents who may complete the task. I mean, acts like suicide sometimes. So therefore, one has to be very careful. And well-tested interventions such as CBT, that is cognitive behavior therapy, requires communication and as well as willfulness to participate in. So therefore, it's a major challenge. You can't exercise the CBT in a child or adolescent with autism spectrum disorder. So therefore, it is a double challenge to us. And then there is a lack of robust evidence of benefits of medication amongst this special population. We do have FDA-approved medication which is available for adolescent in depression in adolescents. But very specifically for children with autism spectrum disorders, the number of studies are very limited, and we need to have more and more studies. And one has to differentiate this particular condition with other disorders such as anxiety disorder. Anxiety disorder is the most common disorder in persons with autism spectrum disorder. Almost 47% of the adolescents can have some anxiety disorders or severe anxiety. So therefore, one has to differentiate it. And there is another condition which is called as disruptive mood dysregulation disorder. In a very challenging condition, you will be presenting with a lot of aggression, irritation, continuously it will be seen without any obvious reasons, lasting for a few months, and it is not having any episodicity like, depression. So therefore, one has to differentiate it between. So to conclude, what I would like to say is depression is a very common condition seen in adolescents with autism spectrum. And if we identify and diagnose depression in appropriate time and provide appropriate intervention, the quality of life of persons with autism spectrum disorders and their family members can be improved. The burden on them as well as professionals working for them can be reduced. And one important thing which we need to keep in mind is that look for recent onset of symptoms, meaning you need to know what is the pre-morbid state and what is the onset and what is the the evolution of the symptom in this particular. Give importance to the behavior rather than thought, how you feel, etc. Give more weightage to the behavior which has been observed by others. Start using objective tools in your clinical practice so that you can help more and more people. Thank you very much.
Thank you.
Thank you, sir. Thank you very much for your presentation. Hello.
Yeah.
Thank you, Dr. Om sir. Thank you very much for your presentation. It is very wonderful and we enjoyed, sir, with your practical inputs in this
Right.
related with, like adults and adolescents with autism. It is a very important and mostly neglected area, I can say. Because most of the professions are focusing on pediatric children, pediatric population with ASD. But few research, I think very few people are doing research on this area.
Right.
For your presentation, and we need in India, we need this kind of research. Thank you, sir. Thank you very much. Next, I take the opportunity to introduce the next third speaker of the day, Dr. Lokesh Lingappa, sir, to deliver his session. His topic is role of genetics in autism spectrum disorder. And about sir, he's a consultant child and adolescent neurologist, and he is a fellow in pediatric neurology, Bristol, United Kingdom, and MRCP-CH, United Kingdom, and currently is having affiliated with the Department of Pediatric Neurology, Rainbow Children's Hospital, Hyderabad. Is the best outgoing student DM Neuro from NIMHANS, Bangalore, and one of the 3 centers for IAP PDF in Pediatric Neurology training program. And is a national, international publication is having so many, and he presented, and critical care neurology in infantile epilepsy, stroke, and teaching areas are his areas of interest. So he is mostly focusing on critical care neurology, infantile epilepsy, and stroke and teaching. Now I welcome Dr. Lokesh Lingappa, sir, to present his session. Over to Dr. Lokesh Lingappa, sir.
Once we diagnose autism, one of the important questions in the parent's mind, and even for us as clinicians or therapists, what caused it? Why it happened to my child? I think that's a $1 billion question. Even today, nobody is able to answer. And autism is one area where you have around 2,500 publications every year. You don't get publications on tubercular meningitis or malaria because you know the cause, you know the treatment, you know the outcomes, most of it. So you don't get as many publications. When you know with very clear clarity what is causing it, then the publications reduce. Only when there is uncertainty about the etiology, treatment, you have lots and lots of publications coming through. So that is why in autism, you have up to almost 3,000 publications, 2,500 to 3,000 publications every year, which comes. So I'll just quickly start the presentation. I've been working with Dr. Om and Dr. Nagaratna in NIMH as well. And currently I continue to work in Rainbow Children's Hospital for last 13 years. And although I'm a neurologist who has keen interest in some developmental pediatrics, because as a neurologist or as a pediatrician or as a developmental pediatrician, you can't escape but looking after these children and families with autistic spectrum disorder. So once we diagnose, as we said, the question is, why did it happen? So we'll have to look at the environmental factors, genetic aspects of the disease. We do a proper clinical evaluation and also take a family history, discussing the genetic testing option wherever is required. Not everybody required to be tested, but in certain particular situations, you need to give them an option, and interpreting those results and their implications and reporting the recurrence risk to parents and counseling on the long-term outcomes or the responsibility of the clinician. So we'll just have an outline of epidemiology. Twin studies give a lot of input into what is the genetic reason, because both of them have born in the same kind of environment in the mother's womb, and they share the same genetic tendency, but some children develop autism, some don't within those twins. So that will give a very good insight into as to what are the genetic factors and what are the environmental factors. What are the technologies available as of today? What are involved in the testing, genetic testing? What are the genes implicated? Is there a role for metabolic testing routinely? And recurrence risk in future pregnancy, and way forward, we'll just go through. We are not going to go through too much of detail because there are a lot of, I know the therapists are also involved, but it is good to know what is current knowledge of genetics, because all of us will be asked this question, because we deal with these families for a long term as therapists. As a doctor, clinician, I will probably see them very infrequently, but as therapists, you see them more regularly, and these questions keep on cropping up there in their minds. So ASD epidemiology, we have already seen this. Dr. Leena spoke about this. So current prevalence is 1 in 59 live births in USA, and probably in Indian data it is around 100. And it is 4 times more common in boys than girls. The reason is still under evaluation. It's not very clear. There are a lot of X-linked genes which are associated with intellectual disability, but not necessarily with the autism. So there was a very large scale study done on 31 lakh children in the Danish population. What we found is almost 1.96, that is 2 per 100 males had autism, which is almost similar to the US data. 2 per 100 males had autism, whereas 1 in 200 females had autism. So that comes down once again to 1:4 ratio if, for the female is to male. So boys are more frequently affected than girls. The reasons are not very clear. So the twin studies, as we discussed, if you take a monozygotic twin versus a dizygotic twin. So monozygotic twins have a higher chance of sharing the same genetic configuration as compared to dizygotic twins. So you expect if a monozygotic twin, one twin has autism, other twin has a higher risk of having autism. So there are studies initially, studies done in 1990s, which showed that almost 76% concordance rate for monozygotic twins to have autism, whereas 0% concordance for dizygotic twin to have autism in 4 studies, which was shown. But later on studies done in 2000s, what they have shown is, if you are a monozygotic twin and one of the twin has autism in the monozygotic twin, the other child has 88% risk of having autism, which is a very, very high risk of having autism. Whereas in a dizygotic twin, it is around 31%, which was 0 in the earlier studies. Now they say around 31% risk of having autistic spectrum disorder if you have a dizygotic. So that is the difference, almost 60% difference between the monozygotic and dizygotic, which is a clear indication to say there is some contribution of genetics, but what is it? Which are the genes? Can we point them out? It is still difficult. So there was one recently published study in 2019 December where they looked at 366 pairs of uniformly phenotyped monozygotic twins with and without ASD. So they compared them, and what they found is the proband wise, if the one proband is diagnosed with autism, the other twin has 96% chance of having autistic spectrum features. Having said that, so that is a high concordance rate, which means that there is a huge tendency of genetic, huge genetic implication here, because they both share very high similar genetic configuration. But what they have noted is there was almost 50% difference in the severity of the symptoms, like the social domain or the interaction domain or the hyperactivity or the intellectual disability. These kind of domains were not exactly matching, although they fit into broad category of ASD, these diagnosed twins, but there is a significant discordance in the severity of to the point of if the child, one child has 50% severity, other child has 100% severity. So there is a significant difference within the monozygotic twins, but both can have almost 96% chance of having autism. So what is the cause for this difference in the severity? That is what they have looked into in this study. What they are proposing is non-shared environmental factors which exclusively occurred during or after birth. During birth, one of the twin might have had suffered some hypoxia, or one of the twin might have had some hypoglycemia. One of the twin probably was IUGR. So those things can contribute to difference in the development and severity of social traits in these autism twins, even within the monozygosity. And ratings on twin social behavior remained highly consistent. So once you rate them very early, the rating remained consistent for a very long period. And all these environmental factors act on these twins prior to age of 4 years. So what they have noted is environmental influences on the genes play a large role, causing the variation of symptoms severity across the autism spectrum. So you definitely have a genetic tendency, but the severity of the manifestation varies based on the early age environmental factors, both intrauterine and the postnatal factors. That is what these elegantly done twin studies have shown. So don't go into the details of this very elegantly drawn graph. So what it shows is, if this is the question, I think very important graph to answer your parents' question according to the current understanding. So if you look at this diagram, almost 50% are due to environment, to de novo variants in the genes, which is also secondary to some environmental changes. So total around 48% are secondary to environmental factors. That is, there is no clear genetic tendency shown. Whereas around 52% have had some form of, not direct genetic variations, but some form of genetic variations. So you have more than 1,000 common variant alleles which are associated with very low risk. So almost 50% are associated with very low risk genetic variants, whereas 2.6% are associated with high risk genetic variants that are called CNVs. We'll come to that. And rare inherited single nucleotide variants which are very causative of the autism. So you have 50% where if you do a genetic study, you find a lot of variations, but exact contribution of them is still being evaluated. So we'll go back to those factors again. When these children come to us, we have to take a detailed history and evaluation, as already developmental pediatrician Dr. Leena has evaluated. So history is suggestive of excellent intellectual disability. Your point goes towards possibility of Fragile X syndrome. So if a child has neurocutaneous markers, many of the children with tuberous sclerosis usually present with epilepsy very early on in infancy. And some children go to the cardiac centers because they have a rhabdomyoma. That's how their diagnosis will be picked up. There is a small population of children where epilepsy is in the background, but autism is so bad. That is how they come to a developmental pediatrician or the psychiatric consultations. So that is another condition where there is almost 30% or more incidence of tuberous sclerosis children. Almost 30% of them have autism. And if you have clues towards any particular genetic condition, Down syndrome, obviously clinically it's very easy to pick up. Fragile X syndrome, you should carefully look for large ears, light circumference which is slightly on the larger side, and broad forehead. All those clinical features need to be looked into. Cornelia-de-Lange is a rare clinical syndrome, and it has many other features including severe failure to thrive, sign of risk, severe intellectual disability, and epilepsy. Angelman syndrome obviously presents with ataxia, almost no speech acquirement, and epilepsy. Rett syndrome is very obvious in most of the female children, but almost in 2.5% of autism girls, it has been shown that they don't have other features of Rett syndrome, but they show genetic mutation in the Rett syndrome gene. So what are the other selected genetic syndromes? Why are we going through this? So most of the times when they walk into the clinic, you know it is autism, even before doing a detailed evaluation. So you can classify them as run-of-the-mill autism, where you don't have additional features. At any point you find any additional features, then we need to look at the genetic syndromes. So if you have a congenital heart disease with autism, you look for 22q11 deletion. If you have epilepsy, ataxia, Angelman syndrome, once again, multiple abnormalities, Chart syndrome, Cornelia-de-Lange, Fragile X we spoke about. Prader-Willi syndrome, usually they present with hypotonia and feeding difficulties in infancy. 10 syndrome will come in detail, and Rett syndrome as well. And tuberous sclerosis we spoke about. So these are the common syndromes wherein they can be associated with more than sort of 20 to 50% association of autism as their manifestation. So just a taster slide to show you different types of genetic testing which are available as of today. All of them are available in India, and it is most cost effective in India. You can see the prices, what is there in US. So it will be 1/10 of these cost in India for most of these tests, or even cheaper than that. So karyotyping generally is not very useful in testing for children with autism. Fish testing, if you are suspecting Angelman syndrome, yes, it is going to be useful. And microarray as one of the important first-line testing in children with autism. And whole exome sequencing is another way of testing to look at these children with autism. So, scary slide. Lots of fishes and other things which are swimming around here. So what we need, I'm trying to get at here is, the researchers are putting their time, effort, money to understand the pathophysiology. What we see as a phenotype involves so much of understanding of all the functions and what happens when there is a problem in any of these genes. We'll just come to the first, the presynaptic genes and the synaptic cleft genes and the postsynaptic genes. So at each and every level, you have genes encoding, and any of the dysfunction of these genes lead on to autism plus many other manifestations. So we have a child with TRKB gene mutation who comes with failure to thrive, non-verbal, autistic, and frequent epileptic seizures. So unless you do a whole exome sequencing, you'll not be able to pick up this child will be labeled as intellectual developmental autistic spectrum disorder. So that is why whenever you have additional features, bad epilepsy early on, significant unexplained failure to thrive, microcephaly, you start thinking of there is something genetic rather than just a run-of-the-mill autism. There are many other genes called neurexins, neuroglians, and calcium channel mutations, SCN2 mutation. SCN1A is commonly associated with epilepsy, whereas SCN2 is associated with a lot of autistic features. Currently, we have 2 children who have developmental delay autistic features who have SCN2 heterozygous mutations. Similarly, there are a lot of mutations in NMDA, green AMPA2 genes, which are not clearly shown to be associated, but they are associated with some forms of autistic spectrum manifestations when there are abnormalities in them. Within this cartoon, this blue colored one are the areas where the Angelman syndrome and Prader-Willi gene are working. So as you know, both Angelman and Prader-Willi are associated with autistic spectrum manifestation. So this is the postsynaptic gene, which has function in the neuronal propagation. And you have mutations in SYNGAP mutation. This presents with SYNGAP gene deletion, presents with intellectual disability and autistic features. Shanks have 3 different types, 1, 2, and 3. They have very high association with autism whenever there is deletion in this Shank genes, which is called Phelan-McDermid syndrome. And similarly, there is Homer gene, DLGs, which are also associated with high risk of autism. All this in red are all associated with autism tendency. These are all postsynaptic genes. So genes working in the synapse, presynaptic, synaptic, postsynaptic, it's mainly with the communication, either the formation of communication, formation of the synapse, all those things are affected, and they in turn give rise to autistic spectrum disorder. FMRP gene are all associated with Fragile X gene. mTOR is your tuberous sclerosis gene. So all these genes are high association with autism. Similarly, where does the MECP2 gene, the Rett syndrome gene, come into action? It is in the chromatin remodeling where it plays a role, and MECP2 gene is essential for the synaptic activity. So as you know, all of our, whatever we are sitting, standing, speaking, everything is minutely monitored by the amount of synaptic activity in the brain. So we have 100 billion neurons and 400 billion supporting cells. So each of them have enormous amount of connections, and all of them have synaptic activity. So whenever genes which are involved in synaptic activity are affected, you have imbalances which can affect lifelong in various manner. So CHD8 and MECP2 are important genes in chromatin remodeling and synaptic activity which cause autism. Are there metabolic disorders which have ASD phenotype? There is a huge list of these conditions, but you would like to be aware that there are 2-3 conditions where you might actually make a difference with your treatment. If you diagnose cerebral folate deficiency, these children present with anemia which gets only corrected with folate deficiency. They can have intractable epileptic spasms. We have one child we are managing currently, and disorders of creatine transport metabolism. where a child with unexplained developmental delay and autism-like features, you have microcephaly especially, you try to do a MRI with MR spectroscopy that will give an answer whether it's a creatine transporter defect, and supplementing with creatine and supportive medications actually can make a little bit of difference in the outcome in creatine transport disorders. So these are other conditions which are seen, we are not very common. You don't have to keep remembering them. So this is for clinicians. So when do you want to be worried about whether we are not dealing with run-of-the-mill autism, we are dealing with something else, I need to investigate more. So a child with autistic spectrum disorder comes with acid-base disturbances repeatedly, comes with anemia which is responsive to either vitamin B12 or folate, cyclical vomiting syndromes, comes with dermatologic changes, alopecia, hypertrichosis, both can be seen with mitochondrial disorders. Developmental regression associated with illness or fever indicates underlying metabolic disorder, including mitochondrial. Gastrointestinal dysfunctions. Hypotonia is a very non-specific symptom. If you examine a child with autism, you find a little bit of hypotonia. But a disproportionate degree of hypotonia or dystonias, you need to think of a underlying metabolic disorder. Unexplained lethargy, multi-system involvement, and any failure to thrive and microcephaly. Be aware that most of the children with autism, run-of-the-mill autism, what we call as, have normal head circumference or slightly on the macrocephalic side. But if you have microcephaly, you need to start worrying about it. That's why I insist all our trainees that you should always document the anthropometry on the first visit. So a child with autism, run-of-the-mill, you find the head circumference is around first centile or third centile, but all the other centiles are at 50th or the 85th centile. You know there is something going on the brain which is not consistent with the simple autism. So those are the things where as a clinician you need to start thinking of things other than autism. And you have a clinical diagnosis of autism. One of the important tests, apart from the Fragile X, which we'll come to, is chromosomal microarray. So you can find a CNVs. We will come to the CNVs in a minute. So if you find CNV variations, which are ASD associated, you should do the family testing. If you don't see any ASD associated CNVs, then whether there are de novo CNVs you need to look at. So with this help of the genetics consultants, we will be able to know what is the significance of the chromosomal microarray. You might find there are no CNVs, then you do other testings. If you find CNVs, you need to consult the genetics for further detailed evaluation. So if you do chromosomal microarray, the yield is around 3 to 5%. So the test costs around 16 to 20,000. And because we have to explain the parents what is the yield of the test when you are sending a expensive testing. So current yield is around 3 to 5%, which might get better with newer advanced forms of microarrays. What is this? I think most of the clinicians, it's easier to pick up. It's a hypopigmented macule, and it's a plaque, hyperpigmented plaque on the face, PUD orange appearance. So this is autistic spectrum disorder in a child with tuberous sclerosis. So these are very clear markers. You don't have to worry about sending genetics in all of them. This is a classical CT scan in these children. So it's a very clear diagnosis, and autism is seen in around 30%, especially more in children who develop what we call bad epilepsy as well. What is this condition? So this is a male child with autism, large forehead, head circumference slightly on the higher side, prominent ears, large philtrum. So it is Fragile X syndrome. So it is very important to clinically pick these things up. So you need to do Fragile X testing in all male patients despite the absence of any characteristic syndrome is the recommendation. And females, X-linked pattern of inheritance of undiagnosed intellectual delays in the family, or family history of Fragile X syndrome or premature ovarian failure is there in the family. So you do Fragile X testing in the females as well. So X-linked pattern of inheritance of undiagnosed intellectual disability, family history of Fragile X syndrome in the female who is affected, or premature ovarian failure. So these are the indications for screening for Fragile X in the girls. So this, hopefully this video plays well. This is a child with florid autistic spectrum disorder, but also has motor delay. You can see that characteristic. We can see that characteristic and automatisms. What is the diagnosis here? Rett syndrome. Okay. So that is a characteristic abnormality movements, what you see, hand wringing movements, abnormal breathing, all those things. So all ASD girls with intellectual delay should be tested for mutations in MECP2 responsible for Rett syndrome. 4% of female autism patients with severe intellectual disability present with damaging mutations in this gene. So you may not have all the autistic, all the features of Rett syndrome, but you have a girl child with autism, severe intellectual delay. Even that combination, we need to test for Rett syndrome because there is 4% chance of picking that. So this is a family tree of a child we tested for unusual syndrome. So this boy came in with developmental delay, auditory agnosia, and regression of speech, had macrocephaly and skin tags. There are two clinical markers here for us. One is large head, which was more than 2 standard deviation, and frontal bossing with skin tags, which is extremely unusual in a child. So this is a file picture from not the index child. You can see some of these skin tags here. And macrocephaly, large head, which is more than 3 standard deviation. So if you have more than 2.5 ST head circumference in a child with autism with skin tags, look for 10 gene, PTEN, which are associated with hamartomas of the skin and macrosomia, macrocephaly. There is a high risk for tumorigenesis in these children. Skin tumors and gut, GIT tumors are there later on. So we need to pick them up early and counsel the family. So this child which we diagnosed was harboring this mutation, also called Cowden syndrome or Balakawa-Ruby syndrome. So what are the genetic testing? 3-generation family tree, examination, specific syndrome suspected, you test accordingly. And then you do microarray for most of them if the family is willing to get it done, explaining that the chance of picking up any abnormality is around 3 to 5% currently. And DNA testing for Fragile X syndrome to be routinely performed for male patients. This is a recommendation by the American Academy of Genetics. For a clinician, you can categorize as a clinically defined syndromes, which you can examine and say, yes, this child has chromosome 22q deletion features or neurofibromatosis, tuberous sclerosis. Another category, molecularly defined, that is only on genetic testing you will be able to know they have underlying genetic features. So ASD risk genes, chromosomal abnormalities, and CNVs. So these two groups are clinically defined, genetically defined, but have a information based on the genetics. Almost 75% may remain unidentified with the current genetic testing. So that is what you can counsel the families. So with extensive testing, you can identify in 25% some form of genetic abnormality. So I will not go through the details of CNVs. The second tier testing will be MECP2 sequence for all females with ASDs. MECP2 duplication testing in males if your phenotype is suggestive. We'll come to that, what phenotype. And if you do whole exome sequencing, you find an answer in 8 to 20%. So you find 3 to 5% answers with the CNV variations in the microarray and 8 to 20% in the whole exome sequencing. So if you combine the yield of metabolic and genetic testing, some of the studies have suggested yield of up to maximum of 30 to 40%, but that is excess. Mostly you get a yield somewhere around 20% in our own population. So important question, especially if the parents want to go for next child, is what is the risk of recurrence? Couple with one affected child has around 3 to 10% risk of having next child with autism. It is higher, it's around 7% if an affected child is a female. It is lower if a first affected child is a male. 2 or more affected children, recurrence risk is 33 to 50%, which is extremely high. So this is a study from Denmark again, where shows relative risk of recurrence. What they have shown is 6.9 times higher than the general population risk. Relative recurrence for maternal half siblings is 2.4, paternal half siblings is 1.5. This once again indicates a significant genetic tendency. So sibling risk stratified according to what if the first child is male and the second born child is male. It is around 12.9% or 13%. So if the first born child is male, you have a second child, the risk of recurrence is around 12.9%. So if you have first born male child, second born child is female, the risk of recurrence is around 4%, which is much less as compared to if the second born child is also male. But if the first born child is a female, that's the index child, if the second born child is a male sibling, the risk of recurrence is around 16.7%. That's a significantly increased. Whereas if first one female child and the second child born is female, the risk of recurrence is around 7.5%. So to summarize, male child, male sibling, higher risk. Female child, first index child, once again the male sib is at a higher risk. This is what in the summary what you can get from this. This is all numbers. I'll come to the last slide which actually summarizes what the parents' feeling is. So just a quick recap. 3-generation family history, detailed identify the syndromes, microarray. In males do Fragile X testing, MECP2 testing in the females. In the males, where are you going to do? If there is excessive drooling, recurrent respiratory infections, hypotonia of facial muscles, very severe intellectual disability they will have, along with pseudobulbar dysfunction because of that recurrent respiratory infections and hypotonia of the facial muscles. In presence of severe intellectual disability, consider MECP2 testing. In the males, not talking of females here. So in the females, MECP2 testing, Fragile X, as we said earlier, any Fragile X tremor ataxia syndrome in the family, you need to do that. Macrocephaly, more than 2.5 standard deviation, 10 gene sequence analysis. So second line testing, whole exome sequencing or whole genome in children and parents. We don't have enough information on what is the yield of whole genome sequencing as of now in autism because large number of studies have not been published as it. If all the genetic counseling has been done for all children with an ASD, negative test, no etiology identified, counsel about the risk based on the sibling studies as we discussed previously. If the test is positive, you explain about the mutation, what is the long-term prognosis, comorbidities, and also offer a testing in the next pregnancy to prevent the recurrence. All forms of genetic testing are available in India, and we usually test after the clinical examination Fragile X syndrome as and when required. Currently, we are not doing in all boys as of now, I think, but the recommendation is to do in all boys. And the MECP2 mutation in girls who have severe intellectual disability and autism, plus minus epilepsy. Clinical examination provides guidance in whom to offer genetic testing. At this point of time, we are doing this. And if any family is going for next pregnancy, we give them this information. This is the risk of recurrence in next pregnancy. So what do you want to do? Do you want to go ahead with the testing? So we offer both the chromosomal microarray and the whole exome sequencing as a test together so that you get almost 20% results within those two tests put together. Another 80%, the chance of recurrence will be population recurrence. So with all this information, what we have, and the mothers were asked, okay, we have given the information about the genetics, ASD heritability knowledge factor into the decision-making process in minority of mothers. So we explain everything. This is a US-based study. Majority of mothers, they knew that recurrence was an option they knew about, but that did not play a major role in their family planning decision. But we need to be very clear, this is a study from one geographic area. It may not apply to all the areas. So the genetic, this one did not play any role in family planning decision. And they had updated knowledge of the numbers, but the parents who were making this decision, especially mothers, were not interested in the numbers we all spoke about so long. So This kind of study is not available, but when we offer the testing for the parents with autism, when they want to plan the next pregnancy, most of them, although it costs around 35,000 for the test, most of them do go for the testing. Yield is very low. We have not had very high yield of this testing unless there are some clinical handles like microcephaly, epilepsy, other behavioral issues, some changes on the MRI, or significant changes on the EEG. So those are the things where we have found either SCN2A mutations, SYN-gap mutations, those kind of things. So currently, autism is a combination of environmental and genetic factors, almost 50-50, although we may not get a single gene defect in this 50%. It is combination of CNVs and very non-specific abnormalities what we see. So overall, genetic yield is going to be less than 20% as of now, or even some population, it might be even less. Modifiable risk factors need to be sought. All children should have their thyroid function testing, hearing assessment to be done, and an EEG if there is slightest doubt of regression. So to look out for Landau-Kleffner syndrome, which are modifiable by your treatment. So look for all those modifiable factors. And currently, the genetic testing is predominantly assess the risk of recurrence in our population. But when there are conditions where like Cowden syndrome, where large head, where the future risk of malignancy and other things are there, we definitely need to offer genetic testing in these families. Thank you. We'll take the questions at the end. Area wherein still there is no clarity, but given the option, I think 2 or 3 testings. One is Fragile X, other one is MECP2 when required, and the chromosomal microarray with whole exome sequencing. These have the best yield for a child with autism to pick up a genetic diagnosis and counsel the families for future. That is what we would do at this point of time. Dr. Jagadish, I am done with my talk.
Yes, sir. Thank you very much.
Okay.
Thank you very much for your presentation on the new topic, which is genetics, which is a upcoming area of interest for every, all professionals, preferably who are, from the background of pediatricians, psychiatrists, neurologists. They are eager to know about the genetics aspect, preferably in the area of ASD. Now you have dealt in detail about this topic, which is a very hot topic, sir. Thank you very much for your excellent presentation, which is very informative with slides and pictures and videos, sir. Thank you very much, Dr. Lokesh, sir. Thank you very much. Now, I would like to call upon the next speaker, Govardanachary Vadla, speech pathology and audiologist from California. And Govardhan?
Yeah.
To Govardanachary? Yes. Yeah. Govardanachary is a member of Arizona Speech and Hearing Association, and Texas Speech and Hearing Association, California and American Speech and Hearing Association, ASHA. And currently he is working in California, in various nursing homes as speech pathology and audiologist. Thank you very much for presenting your session on the differential diagnosis of autism and intervention, a speech language pathologist perspective. I welcome Mr. Govardanachary to take up this topic. Thank you. Go ahead.
Hi, good afternoon. I know it's good morning for me here. It's kind of sleepy too. I'm sleepy a little bit. I'm really, actually, before starting the presentation, I would like to congratulate actually a lot of medical participants, especially pediatricians and psychiatrists. We get more medical diagnosis from pediatricians and psychiatrists here actually. So what is the role of SLP in diagnosis of autism? That's a topic now actually. So there are we can see Dr.Leena went in detail about DSM-5 too, actually the criteria. But if you see, there are 2 major symptoms that differentiates whether they have autism or not, actually. So the first one, persistent deficit in social communication interaction and restricted repetitive pattern of behavior. So it was 3 symptoms before they combined communication and social skills in DSM-5. So you can, if when you look at the first symptom, it's actually uh, everything is related to SLP. So if it, if there is a good speech and language evaluation report, you can differentiate and you can do the clear differential diagnosis of autism. So, what is the differential diagnosis? I mean, this is just the definition. Uh, so, it's distinguishing of a particular condition. In this case, it's a condition from other uh, similar clinical features. So, so what is the need? Why do we need to do the differential diagnosis? It's to eliminate stereotypes of common disorders. What are the common disorders? So actually in 2011, I presented at California Speech and Hearing Association. It's a small study, and you can see these disorders actually show continuum in pragmatic impairment from autism to social language impairment. So you can see that, I mean, social autism, mixed dyslexia, fetal alcohol syndrome, nonverbal learning disability, ADHD, and social anxiety disorder. There's one more thing I didn't address at that time, but the gifted children, other end of the normative curve, actually show a lot of social pragmatic issues similar to autism. So, why do we need to do the differential diagnosis? To reduce the over and under diagnosis. I know we just heard like 1 in 59. That's too much. So we don't know whether we're doing over or under diagnosis. So the differential diagnosis helps to understand the learning styles of the individual, or what is the individual's strengths and weaknesses. Not only that, it helps to plan the intervention plans, intervention programs, and intervention techniques, whatever we use. It's totally different. I'll go in detail why it is very important. And it's to avoid ethical dilemma. That is very, very difficult thing. Actually, whether you don't know whether this child is autistic or just we are misdiagnosing, or that dilemma we don't want to have, right? So that's the reason we have to have the differential diagnosis. So Dr. Leena went through all this the criteria, but I'm just going to show some prominent features. So the first one, a persistent deficit in social communication, social interaction across um, uh, multiple. That is the most important thing. Multiple settings. So it uh, if the deficit or impairment is, or the feature symptom is only at one situation, that means it's not autism. We have to be very careful about that. um, so um, so social emotional reciprocity, so abnormal social approach and failure normal back and forth conversation, reduced sharing of interest, emotions, or affect, failure to initiate or respond to social interactions. I'm just reading. I know you can get this information on web actually from DSM-5. Um, the reason I'm reading is actually just keep these features in your back of your mind, and when we go in details, actually this is helpful. So nonverbal communicative behaviors used for social interactions are difficult. I mean, there's a deficit in that area too. Poorly interpreted nonverbal communication, abnormalities in eye contact, body language, or understanding and using the gestures. So total lack of, again, this last part is very important. Total lack of facial expressions and nonverbal communication. That's the significant symptom of autism. And developing, maintaining, and understanding relationship. So difficulties and adjusting behavior to suit various social contexts. This is very important. We know that different situations. We'll go in detail in the pragmatics part. Difficulties in sharing imaginative play or making friends. Absence of interest in peers. So I don't want to go in detail about the second part of the criteria, the symptom, but just a couple of things we should uh, uh, remember actually. The second part is actually at least two symptoms out of these four. So if the child comes with like flapping hands or walking on toes, it doesn't mean that they have autism, but we have to look into all other aspects also. So, so these differential diagnosis is very important. And the symptoms must be present in the early developmental period. That's the most important aspect. And it should clinically cause they should cause clinically significant impairment in social, occupational, and other important areas of current functioning. And again, this is the last point is very important actually. Again, there is a comorbid condition like intellectual disability and autism. We see most of the kids actually, I think they said like 30% of them. Uh, so we can see when you're diagnosing the comorbid condition, actually, you have to look at the social language skills. I don't know how many of you know about cognitive referencing. Usually, speech therapists use, psychiatrists use actually when compared to your IQ, how much its ability and your cognition. So whether you're performing at your ability level, like a cognitive level. So that cognitive referencing we don't use for diagnosing speech and language impairments, but for autism, actually, we have to use that to see whether this condition is uh, uh, as a comorbid or it is actually just the intellectual disability. Because if the child is like 5 years old of cognition, and if the social language skills are coming around like 7 years, that means that it's not it is not a symptom of autism. It's just intellectual disability. So and the other aspect, actually DSM-5 included one more aspect. I don't know how many of you remember DSM-4, or we used to have the PDD NOS. So those kids are actually fall into this category. In this, only the difference is actually the first part of the autism the symptom only presents, but second part, the repetitive behaviors and all those stuff are not present. So if you see all these, again, just pay attention to these scales. I mean the symptoms. Uh, Again, the deficits in using communication for social purpose, like greeting, sharing information appropriate for social context, and impairment of the ability to change communication. It's again, just remember these points: communication to match context or needs of the listener, classroom versus playground, like child versus adult. We'll go in detail about what falls, which area it falls into in our pragmatic language. So again, following conversation topic and purpose of the conversation. So again, one more additional thing in pragmatic communication disorders is actually difficulties understanding what is not like supralinguistic aspects, non-literal or ambiguous meaning of language skills, idioms, humor, metaphors, and all those good stuff. So again, the similar to the autism, they should start from the early uh, developmental period, and the symptoms are not attributed to another medical or neurological condition or any other speech or language impairment. Some of the speech impairment, if they have syntactic problems, like or some or for morphological deficits, that will result in poor pragmatic scores. So we have to be very careful. So then, so what is, if you see that actually you can divide the pragmatics into three simple categories: situational, discourse, and semantic. Situational is physical context. audience. And again, this course has two of them again, topic and purpose of the conversation. And semantic level, we have visual gestural cues, abstractions, like supralinguistic areas actually, and pragmatic evaluations. So physical context includes where the situation, where's the social situation is occurring. Is it in the playground or in the at house, wherever it is happening, the place. And audience is actually who is in the conversation. Like, is it a child versus adult, or adult versus adult, or authority versus like student? It depends on the person. We change this sentence structures and our way of talking based on the person we're talking to. And topic, like introducing, whether we can introduce a topic appropriately, changing the topic based on the appropriate change, and content is appropriate or not, maintaining the topic, and if there is a breakdown in the conversation, whether they're able to repair it and correct it. So those are the skills come under topic. And purpose, what is the purpose of our conversation? Clarification, giving permission, getting some objects, or giving an opinion, judgment, describing, explaining. There's a lot of good stuff in that area actually. So and visual gestural cues, like monitoring whether he's able to look at the person and see how the person body language and gestures. We monitor that during the conversation. And abstractions, as I said, it is actually supralinguistic aspects. Pragmatic evaluation, when what is the insight of the person, whether he's able to when I did this, and insight kind of thing, and see whether I did that, whether it is appropriate decision I make when that situation occurs. So those are the things. Okay. Those are the things we see in pragmatic evaluation. So what are the prerequisites? So there are a lot of prerequisites there are some are language based, and some are nonverbal prerequisites. So reasoning, problem solving, inferencing, classifying, association, predicting, determining causes, sequencing, understanding directions, theory of mind. I know speech language pathologists can see some of them are actually semantics, language in the area of semantics. See the inference, classifying, association, and sequencing. Those things usually come under the semantic aspects. So theory of mind, those are the things are required for, they're language based. And nonverbal prerequisites are awareness of time, place, environment, and joint reference. So those are the important aspects, prerequisites for the pragmatic development. So how the pragmatic skills develop? Just I think basic information, but we have to understand what goes on actually inside and outside the how the different aspects of our internal and external aspects interact. If some situation is occurring, social situation is occurring, then that situation will have verbal and nonverbal both. So those clues internally they go into the cognitive abilities. Again, it depends on the cognitive abilities, processing abilities, actually whether is able to process the information, whatever is coming through the senses. And linguistic aspects go into linguistic ability skills, whether this sentence is appropriate, what kind of sentence is using, why is it, and why, what is the purpose, and all those things will come into linguistic ability. So then there is again, nonverbal also goes to linguistic abilities. We know that actually, if I say like this, you don't need to, this is a gesture, but it's nonverbal. But in your brain, it shows, okay, this means it is a, linguistically, it actually decodes into saying bye or hi, whatever this context. So again, So you can see there's a always connection between the areas, and then at the end there is neural activity. When it's something is like this happening, actually you're forming the neural pathways in the brain. So again, that connects that again interacts with the cognitive ability processing, and it depends on the processing and the linguistic ability. So at the end, you will get the competency, like whether you're able, you have the skill or not. So this can be expressed or understood by executive functioning. So as you can see, those arrows are actually two-sided. So it is two-sided communication between these areas. So at the end, actually, you can see those are social perception is internally happening and social expression is outside. So then there is actually a beautiful representation of social brain circuitry. The reason I put this is actually, when we go in details, we need this information. So you can see social perception requires actually Miss Amy the amygdala. She is the very smart person, and she's in the center. She is actually a leader. She is like a bottleneck theory. I don't know how many speech therapists remember that. It's a bottleneck theory, right? So all the information is coming to amygdala and then goes out, stands out. So amygdala plays a vital role in social perception and even social cognition. So the social perception requires occipital, temporal, and the parietal lobe interaction, especially actually occipital and temporal lobe. Visual, spatial, and auditory processing takes place in that areas. And you can see the social cognition is actually related to frontal lobe. And you can, the TM is actually theory of mind. The theory of mind in frontal lobe is actually related to the first level of theory of mind. But there is a larger TM here is actually related to higher level, third level of theory of mind. So, and the last one is that the one more actually, executive functioning is related to the frontal lobe. So the familiar working memory is related to parietal and the frontal lobe. So there is a relationship, and the reason I put this is actually a lot of the disorders share or have some of these difficulties, and they actually spill over into other areas. So what is the evaluation process should look like? So just the basic information, as most of us are sharing, actually, we need to have the background information and review the documents properly, get the hearing and vision, family history, and what language information, especially in India, we have a lot of languages. So we need to get the language information and educational history and evaluation history. What did they do any testing before and all this stuff? Is there any interventions before, and what kind of services the child is receiving? So the first and foremost important thing is actually observation of the behavior. As we've seen in the DSM-5 criteria, we have to the symptoms has to be in different settings. So we have to observe the child in different settings. In during the evaluation, classrooms, playgrounds, if you're working in a school setting, or if you're in a clinic, and at home or in playground. So you can do you have to do several observations. So the proper evaluation starts with choosing an appropriate test battery. So first, we have to understand the strengths. And the second important thing is actually prefer learning modality. This is very important actually. Some of the kids you can ask them actually, do you prefer pictures or talking or just listening? So you will get the idea actually what kind of modality they prefer. So you have to know the tests and what kind of tests that are available and what kind of tests are available with you, and whether they are standardized on the population that you're testing student or the child is from, and we have to identify the deficit areas and do at least two evaluations with a speech therapist. This is for a speech therapist, so at least do a couple of tests to see whether the child has is showing the deficit consistently. So and the communication part, you just look what kind of communication the child is using, verbal and non-verbal. And if it is a verbal communication, go ahead and test complete evaluation, semantics. Go and test receptive semantics. This is the most important area in autism, actually, because semantics is actually part of semantics is actually very higher level thinking, and it's a prerequisite for our pragmatic social language skills. So we have to test this, and most of the children with autism, usually we see deficit in semantics. Syntax and morphology, same. Again, receptive and expressive both, and supralinguistic areas. And the pragmatic language, when you're testing, I'm going to share with you the tests that are available, what kind of tests are available, but we have to do prerequisites of pragmatics, whether just awareness or receptive level of pragmatics and expressive level of pragmatics. So if there is a AAC requirement, then go ahead and do that evaluation too. So that gives a full picture of the child. So any area if you feel you need to address, you have to test. So what differential diagnosis is actually most of the, as I said, most of the speech and language impairment disorders at the younger age show similar profile to autism. That's because the speech is only the one that comes first. So they show the impairment in speech or in language initially. So, and the reason is actually genetically spillover to or from the language genes is the reason, or neurologically interrelated as shown in the social circuit. They're all related, and if one area they have a problem, executive function is the area of dysfunction. So in some of the disorders, what happens is actually the spillover, that's the frontal lobe function that might affect the area of mind. So there are a lot of spillover of symptoms. So language delay is the first symptoms, as I said. And what are the common misdiagnoses usually we see? Autism versus NDLD. I know this is a new terminology. I don't know how many of you know nonverbal learning disability. It's similar to autism, actually. I'll show you the slide when I discuss about that. Autism versus ADHD, especially at younger age, and autism versus OCDs, obsessive compulsive disorders, and autism versus mixed dyslexia, and autism versus social anxiety disorders. The last one is actually very important thing is autism versus gifted. So these are the misdiagnoses actually we see most of the time. So what kind of a speech profile we see? Specific aspect of speech language aspects, and let me tell you about NDLD. This nonverbal learning disability is actually in 60s they found this, they profiled it, but it didn't make it to DSM-5. But there is actually practically, I mean, I'm clinically, most of the kids I've seen actually, we can differentiate NDLD from the autism. And I've seen several NDLDs. So their symptoms are actually, they're more, okay, autism is actually, they're more visual learners. But when you see the NDLD, actually, they're more auditory learners. They use more phonological path than the visual path. to learn to decode any visual information. So actually, there was a student he was in high school, and he was a final year of his high school, and high school is your 12th grade. So and the parents wanted to have a speech testing and a language testing actually. So I did the speech and language evaluation, and finally he's actually NDLD. He was diagnosed with the autism. All of his life, they were presenting the information visually. That will not work for the NDLD. So his progress was very, very, very limited. So, um, so that's if you see some of the aspects of the NDLDs, the monotonous speech with little inflection, similar to autism, and difficulty understanding or expressing emotional intonations, um, affect expression especially, and hyperverbal in social context. You can miss this child actually when you have few children with autism. Actually, if you have children with autism and NDLD together, you won't miss this child because he will keep on talking, and he's trying to process the information visually presented to him or her through talking to himself or talking out. So they're hyperverbal, and there will be a lot of empty speech. So as I said, they're auditory learners. So other social perception is an issue. Body language, because there's a visual processing is actually impaired, so they cannot process the information of body language, facial expressions, tone of voice. They miss a lot of information. So that is similar to again autism. So fail to appreciate nuances, same, like similar to autism. Again, they're not only understanding the affects, expressing the affects also is difficult for them. So social interactions is very, very difficult for them because they cannot understand the body language, what's going on. Like 60% of the communication we do through the nonverbal, and they're missing 60%. So only 40% they're trying to understand uh, with. So impaired interpersonal intimacy, and other aspects are so they'll have problem with social judgment, social problem solving, and choosing correct responses, and reasoning and generalization of knowledge. Again, similar to autism, behavioral response to similar situation occurring over time. So there is no consistency. Same situation, but there is the response will be different at different times. So it's always inconsistent. And meaningful difficulty maintain the friendships, similar to autism again. Lack of adaptability, responds poorly to novel circumstances, same again. Primarily anxiety, they'll have depression, and at the end, most of the kids have actually greater risk for suicide. It is sad actually, because the their auditory perception is best, their strength is their verbal comprehension is very good, but and their phonetic analysis is also very good actually. So the simple indications when you're testing, actually you can see they prefer more verbal stimuli over pictures, and poor performance on the test with majority of visual stimuli. I did not include the psychological profile of this but actually performance IQ. So that's the indication. Then ADHD. So the communication issues, we know disrupted receptive language skills. This is an expressive disorganization. They miss a lot of information. They pay attention to the beginning of the conversation or end of the conversation or sentence. So it depends. I mean, some children, it depends on the child actually. Some of the children with the ADHD mixed type, they'll have more issues than the ADHD inattentive and ADHD hyperactive type. So ADHD inattentive type actually most of the time misdiagnosed as a autism. And say verbal reasoning and problem solving skills. They will, because they overlook relevant details. They draw inaccurate conclusions, overlook potential options. Social emotionally, yeah, this is the basic information you guys already know, and lack an overall view of social expectations, especially older adults, older kids, and disturbed relationship with their peers, similar to autism again, difficulty making and keeping friends, same, and deficiencies in appropriate social behavior. There are a lot of studies about that. And again, the issue with the ADHD is monologues rather than dialogue. So compare again, keep that in mind. The features of autism and ADHD. There are several overlapping symptoms. So difficulty taking again, just similar to autism, but the tendency to interrupt frequently. So difficulty following through tasks. These are the basic features of our ADHD. We all know already. Missed social cues, disorganized lifestyle, sharing information that is inappropriate. Yeah, similar to autism. Sometimes they become flooded or overwhelmed, shutting down. Similar, and disorganized or scattered thoughts, rambling or straying off topic. So most of the cases, they say, oh, that if I'm asking about something and the child is saying something that's not at all related to the thing that I'm asking. So again, there is a red flag. Oh, maybe autism. So ending conversation abruptly, and reading between the lines is difficult for them. So mixed dyslexia, that is ADHD, but mixed dyslexia is actually, I know this can be like in 3 hours presentation, but I'm just concise into smaller. So mixed dyslexia can be divided into three. I mean, if you Google, there'll be like hundreds kinds of dyslexias, but if you see, there are the major the three kinds. One is surface dyslexia and phonemic dyslexia. So if there is a mixed dyslexia, usually they have similar, I mean, their visual processing and auditory processing both are blocked. So because of, not blocked, impaired, because of that, they'll have similar issues like autism. So they're rigid and inflexible, seems unaware of nonverbal social cues, gestures, tone of voice. They miss a lot of stuff. Has difficulty making friends, often due to blunt and intensive remarks. So similar, most of the aspects, and all the aspects are, I mean, just you can read those things. That's not related to our present topic, but social perception is an issue with mixed dyslexia. But the intellectual ability is actually spared. Their IQ is very in average range usually. The next thing is social anxiety disorder. This is actually, I've seen several of these students with social anxiety disorder, and most of them show like selective mutism and decrease again. When I said selective mutism, actually, you should ring the bell, and you should actually you should remember in autism diagnosis, it has to be across the settings. So here, only selective places they shows, they won't talk, or there is no topic initiation, there is no main name. So you can see a lot similar profile of autism actually. And last one is gifted. Gifted children actually, they talk a lot. Actually, I dealt with a couple of gifted students, and they were similar. Actually, we have to. So if you get the gifted child to a parent or a person, professional, usually we diagnose him or her to autism actually because they show similar issues. So they talk a lot, may have high level of energy like ADHD, impulsive or inattentive or distractible in some settings, only some setting again. Meltdowns for ADHD, they're always going on all the settings. Meltdowns similar to autism, unusual interest, just like autism, often perfectionist, likely to be introverted, unusual emotional depth, intense feeling and reactions, highly sensitive, preoccupied with own thoughts. So keen and unusual sense of humor. See, every 90% of the features are matching the autism. But there is only one difference actually when you see the gifted and autistic child actually. They autistic children usually have the islands of skills, but they cannot generalize and they cannot use together. I mean, they cannot generalize and they cannot do the divergent thinking at all. But gifted, if you give small information to them, they connect to different different situations and different aspects. The most of the social issues they have usually because of the level of their intelligence and the level of the way they think is not can match. Nobody can match in the surroundings. Like the kids, other kids cannot because these boy or gifted boy thinks like 4 or 5 steps ahead, and other boys like, well, I don't know. So it is kind of unusual for the gifted children to play with the other kids. So that's one of the symptom of gifted. So we have to be very careful. The only difference is generalizing the skills. That's the best thing and best clue for the gifted children. So what are the tests and test batteries that are available? I mean, there are a lot of tests. I don't know in India. That's a problem with our situation there because we have several uh, languages and we don't have many language tests either. So, so the simple thing actually, when you're using Western tests, what is the problem is they are standardized on the Western population. So they're not standardized on Indian population. So I'll give you a simple example. Um, uh, when I came here, my friends used to make fun of me actually, the locals here. I use, okay, our head nodding is actually totally different. We nod head like circle and sides and everywhere. But here, this is, the only two. So for them to understand us actually to difficult for them actually because we are using the head too much. So and when you I mean when you're folding your arms, actually it's a respect for us culturally in Indian context. But when you here, if you do like this, you're rude. So so that's the reason actually when you're using westernized tests, you have to use your um, I mean local or whatever we are cultural aspects we have there, and based on that you have to test. This is a screening test, based simple test actually. There's only one test. I don't know. I didn't find any theory of mind test. Only one test item on PLS5 has a theory of mind. That's all. But other pragmatic skills, there are self-5 pragmatic profile, and there is a checklist. And to check the supralinguistics, we have double meaning and CASTLE. Actually, CASTLE is a pragmatic, it's a test battery. So if you have CASTLE 2, you'll have most of the tests. Again, this is all from the CASTLE 2. And the prerequisites we test with TOPS 3. That actually gives a good information about prerequisites. whether they can make inferences, negative questions, pay attention to negative questions actually, problem solving, and predicting, determining the causes. So there are a lot of information, like the two different kinds they have, adolescents and children, younger kids. And TOEFL 2, there is actually, there are, it's a good test, it's a lengthy test, and it's again subjective test. So the most of the situations you can use actually in Indian situation, TOEFL 2. Castle Pragmatic Language, that's also a very good test. And SLDT Elementary, this is actually exclusive pragmatic test, expressive test. So there are some, it actually tests the prerequisites as well as the other aspects of the pragmatics. So there are two kinds, and there is a C, social emotional evaluation. It's a deep testing kind of thing, whether they're able to facial expressions and all those stuff, motion. And ADAS, I know, the psychologists have only one Brahmastra in there. With them actually is ADAS 2, because it's only the test that actually is we can observe and get all the information. But again, this we are actually the SLPs, actually speech language pathologists, are second raters on this test too. So most of, there are a lot of other rating scales. But again, they're all subjective. Even ADAS 2 is also subjective, but it is actually based on the structured play and all those stuff. So it's better than just getting the information about the child based on the what is that, the rating scales. The problem with the rating scales is actually whoever is rating, actually they look, they remember whatever they remember recently based on that they rate. So that's the difficult aspect to clear it out of the bias. So this is actually in 2011. Actually, I did like a matrix kind of thing. So based on TOEFL 2 is very good actually test. So and I did the evaluate. I took some students. I mean, few samples actually, and analyzed with different kind of disorders. So you can see Asperger's there. I know, just ignore that. At that time, there was Asperger's, autism, mixed dyslexia, and nonverbal learning disability, ADHD, Asperger's, and Pitlock-Carl syndrome. So this is a matrix. Actually, they have to do the test, and there are only 13 items we have to score. And when you score, it is not available actually. It's just my presentation is still in the process of finalizing. So you can just rate the score the numbers, score the aspects. Actually, when you see the TOEFL has test of pragmatic language test, has actually several aspects in one question. So you have to be very careful when you're rating this matrix. So put the numbers in and get the percentage. Usually the percentage is like possible prevalence of whatever disorder, and that is equal to 100 times whatever the score you get divided by 13. So you see here, actually you can see 61%, 61.5% actually shows this student is autistic. And there are like 54, 46, and there are different kind of percentage possibility of those kind of disorders. But to eliminate that again, so this is actually, if it is more than 50%, just put the plus mark. You know that autism is actually auditory processing deficit and intelligence always. And because 61%, put plus mark, plus. And mixed dyslexia is visual and auditory processing. Intelligence is good. So 50 plus, and similar to that, just score that and you'll get the idea. Like 64% of 64% of having auditory processing disorder. So only 50% of the chance here. So overall, when you look at this child has autism with auditory processing disorder. So with our testing, speech language pathologist testing, we can find out what kind of processing issues the child has. So this is not available test, but it's just in the process. Okay, transitioning to adulthood, lot of different set of difficulties compared to children. Actually, it's a rainbow of issues with the children with autism. You know, like every stage of their life will have different kind of issues to deal with. So that's the reason our work, SLP's work, never end. So it's especially when they're older, we have to work on work-related issues, conflict resolution, negotiation skills, describing, explaining, all those good skills. And personal life, yeah, now I don't know how it is, but usually they will have dating issues where we have to teach them with how to date the girl or boy, whatever, and maintaining relationship. So we have to give therapy on those things too. So as I said, SLP work never ends. So what are the interventions? I know it took a long time, but let me finish with just a little bit of intervention strategies we usually use. My favorite, I know you can see that there, but the social scripts are very good, and the social skills groups, it depends on the child actually. So what the level the child is. So the social skills groups are actually very good for the little bit milder to moderate autistic children, because they're just role play and direct instruction. It includes direct instruction, role playing, and feedback. So it's very good. And even social stories are very structured intervention. So that's the best thing to do. And if it is non-verbal child, do the PECs, or I'll just caution you with the PECs bit, because it's just if you use the PECs strategy completely as they said, actually the verbal language skills are not that much actually after a year or two. But when you modify the PECs and then give the intervention in therapy, then actually you will get even verbal language skills better actually. So that's all I think I have. Thank you very much, and it's a long presentation, but if you have any questions, I know there are a lot of information, maybe new, or you already have questions, just let me know.
Thank you. Thank you, Govardhan.
Thank you.
Thank you, Govardhan Chari, for your presentation. In depth about speech, language, pathology, and audiology. Test, scales, intervention, everything. Thanks for your time. Good evening, everyone. This is Dr. Jagadish, newborn and pediatric early interventionist in developmental disabilities, Department of Pediatrics, Apollo Institute of Medical Sciences and Research, Hyderabad. I welcome you all to this session. I'm going to discuss about the evidence-based interventions for the child with autism. This is one of the very, very important topic after the screening, after the diagnosis, the intervention part. So many interventions are available nowadays globally. Some are conventional, some are scientific, some are evidence-based, some are non-evidence-based. So we have to discriminate all these interventions, and we should know what about each and every intervention. So let us go in detail about this. And comes to the autism. What exactly autism means? It is always unique, totally intelligent, sometimes mysterious. Like even we also sometimes we exhibit and we express mysterious behavior. Even though we are having the normal intelligence quotient or IQ levels, sometimes we behave mysteriously. So autistic child also will behave mysteriously sometimes. And of course, most of the autistic children are intelligent. They also will be having normal IQ levels. So autism means always unique, totally intelligent, and sometimes mysterious. This we need to know about autism. And Every person in this world will be having two aspects. One is abilities and disabilities, and skills as well as skill deficits, strengths and weaknesses. Just like that, autistic child also will be having some strengths. So let us see the strengths in the child with autism. One is the reading skill. The child with autism will be having exceptional reading skills sometimes, and also they will be good at exceptional coordination or the balance, and they are good at drawing skills and computer skills, and they will be having exceptional memory also, and they are good at music skills also. So if we look at the list of the scientists, there are some scientists who got identified with autism during their early childhood. One of is Albert Einstein and Sir Isaac Newton, etc. Even nowadays, we can see the latest information and news. An autistic child among Central Board of Secondary Education class, 10 toppers in United Arab Emirates. And there is another child, his name is Pranav. He is the India's first male model with autism. And also there is another child, his name is Chatterjee. He scores over 89% in Central Board of Secondary Education. So here, by seeing all these, we can conclude that autistic children will be having abilities and strengths, which we need to understand, which we need to identify at earliest to enhance those skills and abilities. And if we look at the incidence and prevalence in the globe, the worldwide prevalence of autistic spectrum disorder is 1 to 2%. When we look at the Indian statistics census, it is nearly 13 million people in India are suffering with autism. So it is becoming one of the epidemic, I can say that. And when we look at the comorbidity and associated conditions in autism, like aggression, attention deficit and hyperactivity disorder, which is very common in ASD children, and some gastrointestinal dysfunction, and sleep disturbances like parasomnia, insomnia, hypersomnia, etc., and motor problems like apraxia, and language disorders, intellectual disabilities, obsessive compulsive disorder, immune dysfunction, and some kind of epilepsy, even social anxiety and social impairment, and some kind of restrictive and repetitive interest, and speech communication deficits. So there are so many associated conditions you can see in the child with autism. And when it comes to a therapy, how to select therapy, this is very important, how to choose the therapy. So once the diagnosis is made, immediately we have to start the therapy. And which therapy, whether it is speech language communication therapy, or whether it is sensory therapy, or whether it is some medication or pharmacotherapy, etc., we need to decide immediately without delay. And what therapy is really and what involves what, this is also we have to consider. And is it a very effective treatment, or is it a cost-effective treatment? And is it a safe therapy, or is it a harmful therapy, like in the case of chelation therapy, etc.? And is there any scientific evidence for this therapy? This also we need to consider. And who is the right therapist, who is the right doctor, how to go ahead and how to select the doctor and how to select the therapist. There are some concerns, from the parent side. These are the concerns which we need to understand at initial part. And before going to the therapeutic intervention program, we need to evaluate the child in various domains like gross motor, fine motor, personal skills, social skills, speech language communication skills, even sensory aspect, as well as, like socialization skills, adaptive skills. There are so many types of, domains. So we need to understand, we need to screen, we need to diagnose, we need to assess the child in all domains. So who has to do this? It is not a one man's job. So multidisciplinary team has to involve here. So who are the people, under multidisciplinary team? So the first is general physician and the family physician. Then after a pediatrician, then the pediatric psychiatrist and pediatric neurologist, and developmental and behavioral pediatrician, occupational therapist, speech language pathology and audiologist, a physiotherapist and behavioral analyst, and special educator, a clinical psychologist or rehabilitation psychologist. So multidisciplinary team consisting of so many professionals. So every professional will be having his own unique role in assessing and prescribing or indicating the therapy. And comes to the evidence-based interventions for the children with autism spectrum disorder. Under this is a very important, we need to identify the red flags at earliest so that early intervention program can be possible. When we identify the child with any developmental delay or difficulty, we need to identify, we need to screen, we need to evaluate, and we need to start the intervention as soon as possible without any delay for the betterment of the child's future. That is why early intervention plays a vital role in any kind of neurodevelopmental disabilities or disorders or difficulties. And the rationale of this session is to take a right decision before selecting and implementing evidence-based intervention programs. And nowadays, what is happening? There are so many unsupported and often, controversial interventions like conventional intervention programs or therapies are indicated to the child with autistic spectrum disorder. So those are non-evidence therapies. Most of the therapies are non-evidence based. So we need to know what are the evidence-based and what are the non-evidence-based intervention programs for the child with neurodevelopmental disability, including medical as well as behavioral intervention programs. So before that, we need to consider some basic principles of effective early intervention program. So you have to intervene the child as soon as possible after the diagnosis. This is a very important, without any delay. You should not do shopping of the doctors or therapists. We have to start immediately if you identify any kind of delay. And also the intensive intervention program is very important for the child after identification. So you need to engage the child minimum 25 hours per week for 12 months per year. And also there should be a low student and ratio, student and teacher ratio, preferably in inclusive schools or special schools. The child and as well as the teacher ratio should be 1:5 or 1:6 maximum for individualized education program or individualized early intervention program. And comes to the family. Family plays a vital role here. Without parental involvement, no therapy will be successful. So we have to inculcate some kind of training programs or inputs to the parents also by conducting parent training programs or parent sensitization programs. And also we should not neglect the peer group, because peer group plays a vital role here. So we have to make the child to interact, provide the opportunity to the child to interact with the peers, preferably in neighborhood as well as in the schools. And also we have to use the assessment-based curriculum. So how to use assessment-based curriculum for what skill development? There are so many skills like personal skills, social skills, adaptive skills. There are so many skills we can develop after the assessment. And here one thing is very important, that not all evidence-based practices are effective for the children with the autistic spectrum disorder. So here no treatment in autistic spectrum disorder works for all children. This is also one of the very important which we need to understand. Earlier, we used to go to the doctors or professionals for the medical information. But nowadays we are approaching the internet doctor, that is Dr. Google. So this is, don't rely on Dr. Google. You may develop cyberchondria. Cyberchondria is one of the syndrome, idiotry syndrome. Internet derived information obstructing the treatment. So you have to be very cautious before approaching the internet. And comes to the taxonomical classification of the therapies. Which are the therapies? How many types of therapies? What therapies are available for the child with a neurodevelopmental disorder, preferably autistic spectrum disorder? Let us see. So biological treatments and non-biological treatments. There are two types of therapies. One is biological. Under biological, what will come? Let us see. The dietary modifications, vitamins, supplements, chelation therapy, and melatonin, antibiotics, antifungals, immunoglobulins, and hyperbaric oxygen. This hyperbaric oxygen also comes under biological. And when it comes to the non-biological treatment, that is AIT, that is auditory integration therapy, and behavioral intervention programs, and craniosacral manipulations, music therapy, and yoga therapy, and sensory integration therapy. These will come under non-biological treatments. And comes to the psychosocial interventions. There is a list of psychosocial interventions like applied behavioral analysis, cognitive behavioral therapy, that is CBT, and supportive psychotherapy. And also speech language communication therapy and our communication therapy. This is for reciprocal communication. And also education therapy, that is nothing but special education. And occupational therapy, that is nothing but sensory therapies. and pharmacotherapy and nutritional therapy. There are so many therapies are available which are evidence-based. And there are some other list of the therapies which are non-evidence-based, which we need to know, which we need to aware. So those are the therapies you have to have a look at once. Aromatherapy, massage therapy, hippotherapy. Hippotherapy is nothing but horseback riding. It is a hypothesis that with hippotherapy, the child with autism may develop coordination as well as balance and posture, etc. And yoga therapy and aquatic therapy or swimming pool, that is pool therapy, and also craniosacral massage and music therapy. These are the therapies which are non-evidence based. So kindly do not focus on these. So focus on only evidence-based practices in intervention programs. So all of us, we need to bridge the gap between the child with autism towards the integration or mainstream. And comes to the interventions. So before going to interventions, we need to consider one standard protocol criteria. Let us see what are the components of this criteria. The first one is evidence of effectiveness. We have to see whether this therapy is going to be effective or not. So the effectiveness of the therapy, this also we should consider. Then clinical decision making. So the professional, he may be a speech therapist, or he may be occupational therapist, or a special educator, or a physician. They have to take proper clinical decision making before prescribing the particular therapy or indicating the therapy to a child or a family. Then also we should consider the families. Why? Because the families, their values is very important in the therapy. So values and preferences of the family we need to consider. That is also one of the important aspect of criteria. Then capacity to accurately implement an intervention program. So the parents should be able to access the therapy. This is also one of the very important, that is cost effective of the therapy. And there are so many 27 evidence-based practices are there, but we don't want to go in detail because there is not requirement also. Only thing is there are some therapies which are very essential to be known. So let us see one by one. Before that, the behaviorist theory, if we look at the behaviorist theory, we may not know what goes on inside the brain, but we can certainly see what happens on the outside. Let's see, measure behaviors and learn to modify them with behavior reinforces or rewards. If we like it, reward it. If we do not, then punish it. This is as per the Eric Jensen. There is a book on teaching with the poverty in mind. It's an excellent book. You can go through this. And it comes to the applied behavioral analysis. This is ABA. Applied behavioral analysis is one of the technique applying behavioral principles to change the specific behaviors and simultaneously evaluating the effectiveness of the intervention. So here it is emphasizes, ABA emphasizes on the remediation as well as prevention. And you should start before the age of 5 years. This is a very important. We have to initiate this ABA before the age of 5 years for effective improvement. And the age range covers here is 18 months to 9 years. So we can prescribe this applied behavioral analysis techniques or training to a child from 18 months to 9 years of age. And the next is the applied behavioral analysis can be applied in various settings like schools, institutions, industrial settings, hospitals, even animal trainings also nowadays. So who are the people who will implement our applied behavioral analysis? So there are some professionals like behavioral psychologists and the teachers, certified behavioral analyst, and speech pathology and audiologist. All these people can apply this behavioral techniques. So applied behavioral analysis delivered through as little as 1 hour per week of parent training. This is a very important. So if we train the parents, it will be very effective in reducing behavioral problems and building social communication in children with autism. So we need to train the child. And this is a very, very important here. Applied behavioral analysis, again subclassified into, there are so many therapies under ABA. One is discrete trial training, pivotal response training, functional communication training, and modeling, reinforcement, naturalistic ABA. Let us see one by one. Discrete trial training, DTT. It is a discriminative stimulus is presented when the child responds. So when the child is responding, you have to present a stimulus, which is discriminative in nature. Then the child receives a consequence, that is reinforcement or reward, which is again based on the response to encourage the skill or new skill acquisition. That is about discrete trial training. And it should be one-to-one instructional approach. And what are the areas which we can taught here? DTT is behavioral as well as communication skills can be learnt or can be taught. And it can be taught in small repetitive steps at each trial. This is very important. And here the positive praise or tangible rewards are used as reinforcers for a desirable skill and behaviors. And we can prescribe this therapy for the age 2 to 9 years of the children with autistic spectrum disorder. And next is pivotal response training. The main principles of this training is based on applied behavioral analysis. This will be developed on the basis of the child's initiatives as well as the areas of interest. And the skills which we can develop here, this is social skill, play skill, and language skill and communication skill. So these are the skills which we can develop with the pivotal response training. And the age for which we can prescribe this PRT, pivotal response training, is 3 to 9 years of age. Then functional communication training. So after functional behavioral analysis, socially appropriate behaviors are taught as replacements for problematic or undesirable or socially unacceptable behaviors. So here, with the first, the problematic behavior has to be identified, then after analyzed, so that we can determine its communicative function through functional behavioral analysis, which is very important. And then a replacement behavior is taught to take its place. This is about functional communication training. And here we can prescribe this training from birth to 21 years of the age. And it comes to the modeling. This is another therapy, providing and demonstration of the good behavior and combined with the prompting and reinforcement. So if we prompt, if we provide reinforcement which are positive, naturally the child will be learning in the form of demonstration. So when we demonstrate with the proper prompting, the child will learn. This is nothing but modeling. Then reinforcement or rewards. If a consequence increases, the probability that occurs, a behavior will occur again and again. This is very important. It can be said to be a reinforcer or a reward. So there are two types of reinforcement. One is the positive, second one is the negative. When it is positive, offering incentives to reward a behavior, like example, token economy, social rewards, or primary rewards like eatables for a younger child. Even sometimes it may be activity rewards also, or a praising also. And negative reinforcement. And when it is negative reinforcement, it involves removing an aversive stimulus to reward a behavior. That is about reinforcement. Then naturalistic intervention is another therapy. This is nothing but arranging the environment or modification of the arrangement or modification of the environment, and also interaction techniques and behavioral strategies that are used to promote appropriate communication and social skills. So this we can prescribe to the child from birth to 9 years, which is a naturalistic intervention in the home environment. Then CBI, that is cognitive behavioral intervention. These are the interventions which will emphasize teaching children to monitor and manage their own thoughts, nothing but cognitive process like thoughts and feelings and behaviors. This we can prescribe to the child from 6 to 18 years of age up to. Then augmentative and alternative communication. These are for expressive communication deficits, because the child with autism will be having expressive communication deficits. So here we can use the sign language to picture systems, and also we can use electronic communication devices. And there is another therapy, that is exercise or physical activity. The child with autistic spectrum disorder may have like attention deficit and hyperactivity disorder as a comorbid or associated condition. So for the child with ADHD, preferably the moderate and severe, we can prescribe or recommend the exercise or constructive physical activity to reduce the hyperactivity behavior and to increase the attention and concentration span. And another therapy that is joint attention intervention. And in this joint attention interventions, it will teach a child to respond to the non-verbal social bits of others. Like examples, when we pointing, to the objects and showing items or activities to another person, and even following the visual gaze, etc. This is very commonly prescribed to the child from birth to 5 years of the age. Then parent implemented intervention is very important, which is not happening in reality nowadays. Actually, it is the duty of the therapist to train the parents also, not only the child but also parents, because parents are taught to provide individualized intervention to their child to improve or to increase a wide variety of skills, including social skills, adaptive skills, personal skills, etc., or to decrease some undesirable as well as problematic behaviors. Parents learn to implement practices in their home and community through a structured parent training program. So it is our duty as a professional, we need to conduct sensitizing programs to the parents also. And peer-mediated instruction and intervention. So peer group plays a vital role, as I said earlier, to acquire new behavior and to acquire communication and social skills. We need to involve the peer group. So it's like it happens in inclusive education. And this is prescribed commonly for the child from 3 to 14 years of the age. Like this is our integrated play groups, which promotes socialization skills and imagination skills through play with non-disabled peers. Create a proper and appropriate, play environment and selection of the materials. This is a very important. So we are integrating the child with non-disabled peers. So here there is a chance of acquiring new skills, preferably the social skills, language skills, and also cognitive or intelligence skills. And the next one is picture exchange communication system, that is PECS. It is totally based on two aspects. One is the verbal behavior, second is applied behavioral analysis principles. So by using the pictures, we can develop certain desirable skills in the child. PECS has also been used to decrease unacceptable and socially unacceptable behavior and problematic behaviors and also undesirable behaviors. This is one more advantage of the PECS. And for children with expressive language difficulties, like in the child with autism, we can use this. Children are trying to exchange picture cards for desired items for which the trainer pairs or joins with a verbal label for that item. So this is the very important, joining the verbal label as well as with the exchange of picture card for effective learning or acquisition of the skill. And this can be prescribed for the child from 3 to 12 years of the age. So this is the slide of PECS or cards. You can have a look here. And one more is the prompting. Prompting are generally given before or as a learner attempts to use a skill. So it may be a verbal prompt, it may be a gestural prompt, or it may be a modal prompt. Modal prompts are nothing but giving a kind of object or item, even sometimes peers also as a models. And this can be prescribed for the age from 2 to 22 years of the age. And early intensive behavior intervention, EIBI. So this is a very individualized program, and it is more comprehensive program, and it should be carried by trained professional only. And this can be done at institution, even at the home also. And parents can be trained in this, very important parents training, as I told you. And minimum 20 minutes this program should be carried, and also maximum 30 to 35 sessions per week for effective improvement. And for borderline and mild autistic children, scripting as well as self-management techniques are very useful. Scripting is nothing but it involves developing a verbal or written script about a specific skill or situation, which serves as a model for the child. So the child will see that verbal or a written script, he will hear, so that he will, repeatedly he will use that in a particular or a actual situation. This is nothing but scripting. And self-management. Learners with autism are taught to discriminate or differentiate between appropriate and inappropriate behaviors, because the child with autism should understand which is appropriate behavior, which is inappropriate behavior, and accurately monitor and record their own behaviors. Here, one more interesting is the reward themselves. So the child with autism can reward himself or herself for behaving appropriately. That is about self-management techniques. And social skill programs. So social skills program groups, these groups including maximum 2 to 8 of children, and also you can include a teacher or a parent or an adult. And most skill group meetings including like instruction, giving instruction, and also role playing and practicing the particular activity on regular basis. So by this social skill groups, the child with autism will learn the personal skills, social skills, speech language communication skills, etc. Preferably it happens in the special schools, even inclusive schools nowadays. And speech generating devices. These are nothing but nowadays, the technological, like electronic devices that are portable in nature and can produce either a synthetic and digital speech for the user, and can be used with graphic symbols or alphabet keys. And task analysis, it is nothing but breaking the main task into the subtask and teaching the child, one by one task with proper, reinforcement schedules and motivation strategies, etc. Like in the areas of self-care, the activities of daily living like brushing, bathing, toileting, and grooming, etc. And also work tasks, as well as the academic aspect and behavioral aspect, and communication, play, and social and transition related skills. So it is one of the very effective method for teaching a child with autism. So autistic child can be learned with the help of task analysis method also. Then the time delay, it focuses on fading the use of prompts during the instructional activities. Here, certain skills can be learned with this time delay technique or therapy or intervention, like academic skills, communication skills, play skills, and social skills. Here, a brief delay is provided, like maybe half a minute or some 30 seconds or 40 seconds delay is provided between the initial instruction and any additional instructions or the prompts, maybe verbal prompts, etc. This can be prescribed for the child from 6 to 11 years of the age. Then one more very popular method, that is teach, training and education of autistic related communication for handicapped children. So this is totally based on the culture of autism. To meet the individual needs of the child, the parents and the teachers and professionals are taught about development of structured teaching program. Here in this teach program, visual cues are provided and can be used. So this program is indicated for the child from birth to 18 years of the age. Then video modeling. There are so many video modeling nowadays are available. Techniques like video modeling, video self-modeling, point of view video modeling, then video prompting, etc. So the child will, he himself take the video and he himself, self-motivate or self-check or self-direction he can do on his own, and also selfly he can prompt himself. So this is about video modeling. And visual supports. There are so many visual supports we can prescribe or recommend to the child with autism, like pictures, written words, objects within the environment, arrangement of the environment, visual boundaries, labels, timelines, scripts, etc. There are so many things which we can provide to the child with autism in the home environment as well as in the school environment or institution environment. So with these, the child can access the activity. Then sensory integration. So there are some principles of sensory integration, neuroplasticity. Either you have to use it or lose it, and use it and improve it. Specificity, repetition matters. Preferably the sensory therapy should be repeated again and again. Why? Because the child with the autistic spectrum disorder will be having sensory difficulties like hyper or hypo. So here we need to repeat. So repetition matters here. Then also salience matters, age of the child also matters, transference matters, interference and time also matters. The time and the duration and the quality of time and the quality of duration also matters in sensory integration therapy. And it comes to the pharmacotherapy, there are so many pharmacological drugs are available for the child with autistic spectrum disorder with comorbidity problems, like the child who is having the irritability or hyperactivity or anxiety. Generally the pediatric neurologist or pediatricians or psychiatrists will prescribe the risperidone as well as aripiprazole for the 5 to 16 years of age children. And methylphenidate also is one of the psychostimulant which is very effective in reducing symptoms of inattention as well as hyperactivity in children with autism. Why? Because most of the children with autism will be having this attention deficit and hyperactivity disorder. So hyperactivity you can reduce with methylphenidate. And this is one of the controversial diet, that is gluten and casein free diet. So if we look at the background here, gluten is nothing but protein found in wheat and rye and barley, etc. Even casein also. Casein is a protein found in dairy products. So there is an hypothesis that gluten and casein break down into opioid-like peptides. They diffuse across an abnormally permeable gastrointestinal lining. That is nothing but a leaky gut theory. So it is a theory, it is there already. Excess opiate activity in central nervous system results in symptoms of autism. So there is a Cochrane review 2009 which indicates very clearly mentioned that there is insufficient evidence for this gluten and casein free diet. It is strongly recommended that a physician or a professional, preferably the pediatrician or general physician, should test for the food allergies before beginning this diet therapy. And it is very stressful for the family because, for example, the child who is growing like young child like 5 years or 6 years, he definitely he likes the sweets and sugars or chocolates or wheat item. But here, if we not give this kind of items, definitely it will affect the child's health as well as metabolism. So we have to keep in the mind. So before this prescription, we need to consult the nutritionist as well as other professionals before prescribing this gluten and casein free diet. And comes to the chelation therapy. This is one of the controversial therapy again. Agents used to bind and remove heavy metals from the body, like lead poisoning. There is a hypothesis that the children with autistic spectrum disorder have HG, that is mercury toxicity or mercury poisoning. So in 1998, there was a myth that because of the vaccination, the children will get autism. But this theory has been debunked because of measles vaccine, post-measles sequelae. If you look at the after measles administration, most of the parents, they say that my child, speech language communication has been declined, so the regression happened. They say like that. But scientific research proved and very clearly stated that it is not at all connected with the vaccination. And chelation therapy is a very potential dangerous treatment for HG and other heavy metal poisoning, that is mercury and other heavy metal poisoning. So this has to be prevented. Then melatonin. Melatonin is a hormone produced by the pineal gland that regulates sleep. So it is available as a nutritional supplement nowadays. And most of the children with autism will be having sleep problems like hypersomnia or hyposomnia or insomnia, sleeping sickness, etc. Like 44 to 83% of the children on average will be having the sleep problems. So evidence of abnormal melatonin regulation in autism. So clinical studies have shown some effect with melatonin. Then secretin, it is a gastrointestinal peptide hormone and which has received attention as a potential cure for autism. But controlled research indicates that secretin has no benefit for individuals with autism. So you can avoid here this one also. And it comes to the vitamins and dietary supplements. Carnosine thought to have an antioxidant activity and role in production of neurotransmitter, that is GABA, and which may lead to hyperactivity. So we have to be very cautious about this carnosine. The second is dimethylglycine, which increases immune function and decreases the inflammation. An earlier study reported improvements in speech, language, and communication when children with disabilities were given this dimethylglycine. And omega-3 fatty acids, of course, neuroprotective benefits will be there. And preliminary studies have shown mixed but promising results for improving behavior in children with autism. Generally thought to be safe. And some studies show decreased levels of omega-3 acids, in autistic children. But the main side effect of, with omega-3 fatty acids is GI upset, that is gastrointestinal upset. So these are the vitamins. We have to be very cautious. And comes to the probiotics. Probiotics are indicated generally for the bacterial and fungal growths. And beneficial effects of probiotics have been shown some kind of like syndromes like irritable bowel syndrome and acute gastroenteritis and urinary tract infection, etc. But meaningful research has not been done on the use of these probiotics in the case of the child with autism. So generally thought to be safe here. And vitamin A, that is cod liver oil, and it improves the immune function and vision. But here we have to keep in the mind that it may cause hepatotoxicity if excess dose has given or administered. And also there will be a chance of increasing of intracranial pressure. And vitamin B6, that is pyridoxine. Here the pediatricians should advise parents of the risk of the B6 toxicity, that is peripheral neuropathy. And also magnesium toxicity, that is changes in the mental status and gastrointestinal upset and muscle weakness and respiratory depression and hypotension and some kinds of erythemiasis, etc. We have to be very cautious before prescribing of all these vitamins, because hypervitaminosis also may cause some problems. And vitamin B6 and magnesium generally safe, but toxicity may occur at elevated doses. Then cobalamin, that is vitamin B12, it can be given as intramuscular in the form of in conjunction with oral folinic acid to counteract, to decrease the plasma antioxidant concentrations. So there was a study, 20 children with spectrum. Initial research showed positive results, but attempts to replicate the findings were unsuccessful. And vitamin C, that is nothing but ascorbic acid, shown to decrease the stereotypic or repetitive behaviors in the child with autism in double-blind, placebo-controlled study that was never replicated. So here the toxicity causes, stones in the kidneys, that is nephrolithiasis and also gastrointestinal upset. And antifungal agent therapy. There is a hypothesis about this also, that the bacteria, like in the gut, cause autism. And since antifungal medications can eliminate bacteria, they believe they can simultaneously cure the autism. But it is potentially dangerous and harmful, preferably in case of antifungal agent therapy. Then raw camel milk. There is no scientific research that upholds claims that raw camel milk is an autism cure all. Then hyperbaric oxygen therapy is proven effective for treatments of gangrene. But carbon monoxide poisoning, no evidence to support this in the case of autistic spectrum disorder. And stem cell therapy, no guarantee that the stem cells used in this therapy are even human. So we have to be very cautious here. And bleach therapy, hypothesis that bleach can eliminate bacteria and some kind of intestinal parasites and yeast and heavy metals and consequently eliminate autism. So this is also not evidence-based. Then the transcranial magnetic stimulation, currently used to treat the mental illness, including depression as well as schizophrenia, etc. And finally, I want to say something to the parents, that for parents, common areas of the parents which are main concerns, like they may feel burdened with everyday responsibility of caring child with autism. And they may feel pressure to become an autism expert and learn everything overnight. And they may worry about child and family's future. And they may have difficulty in finding balance and time to manage household chores, other children, as well as daily activities, etc. And they may be less inclined to share feelings. They may become stressed because of the family finances as well as unknown of the situation. And also there is a chance of development of stress as well as generalized anxiety that can affect their work life. And the main role of the parents, what are the do's and what are the do nots? Here, let us see here. Please do seek professional advice. Maybe a speech therapist, maybe an occupational therapist, or a pediatrician, or a pediatric neurologist, or a occupational therapist or a special educator immediately upon seeing the red flags. So do not ignore or avoid the issue. Please do not wait for the secondary diagnosis or tertiary diagnosis, and don't do the doctor shopping, please, at all. And please do not blame yourself for this child, and do your own research on the best kind of therapy for your child. then start it very quickly and very early. And do ensure consistency of the approach in your home and the therapy. Like, for example, your child is attending speech therapy or sensory therapy. The same thing should happen here also. I mean, you have to give follow-up of the same therapy at the home also, so that the effectiveness of the therapy will be very nice and very good. And do not give in to tantrums and behavioral excesses. And don't rearrange your whole life around your child. Do have open discussions with your child's behavioral analyst, or your professional, or a psychologist, or a therapist, or a like occupational therapist, or special educator, or a doctor. Explain your desired goals and how you believe in your child progressing. And there is a refrigerator mother's concept theory was there. Due to lack of maternal warmth, and due to lack of not loving their children enough also, may cause autism during the early childhood days. So kindly give the time, quality time to your child. This is the very important thing. And also like there is a nowadays, because of working nature, most of the parents they are busy with their lifestyle, works and all. They are not giving sufficient time to the child who is having this autism. So kindly pay attention and give quality of time to your child. Then autism to be caused to decreased interaction offered by the parents and caregivers and society. So he already Kanner said this. So this is the very, very important, that extreme aloneness and aloofness and isolation also may cause autism during the early childhood. And also excessive electronic exposure, like gadgets, toys, mobile phones, screen time, aloofness, human interaction. So these are all things like nowadays most of the people are exposed, even the young children are exposed to electronic gadgets. So because of this also, there is a chance of getting autism, preferably below 1 year of age. If the child exposed to electronic gadgets like a robotic life, the child also may behave like a robotic. So you have to be very cautious in this aspect of electronic gadgets. And and here nowadays what I observed here is electronic gadgets exposure is happening everywhere, in the home as well as outside also with the peers. So that has to be controlled by the parents, and when the electronic gadget has to be given and when not to be given, because there are some benefits also are there. So what I want to tell you is the parents should have a control over the electronic gadgets, and do learn to reinforce positive behavior. This is a very important for the parents. And do be patient and stay positive yourself, and take responsibility in the therapy as well as training program of your child. And you are be a leader, and you should be a leader in multidisciplinary team. And also you have to learn the training program as well as therapies from the experts. So you have to be an expert here, and think critically and speak with authority and be proactive. This is a very important. And you have to document each and every schedule and behavioral events and incidents of your child. So after documenting, you have to report to your concerned therapist for better modification of the therapeutic intervention program. And you have to collaborate, and you have to be a team builder, and you have to educate yourself and be a voice for your child. Okay. So what not to miss here? The thing is, the holistic approach should not miss, like innovative culture related and also habituation models. We should not miss these things, because if we miss these cultural aspects, it will affect the child's therapeutic intervention program. And excessive electronic gadgets exposure may damage the child, like it can cause speech language communication developmental delay and attention deficit, and also learning problems, sleep problems, anxiety problem, and childhood depression. And these are my references. That is, Indian Academy of Pediatrics has now published evidence-based guidelines to help the doctors and the neurodevelopmental disabilities. And thank you very much. This is the open to the audience. Any doubts or clarifications, please raise your hand and do ask. The panelist will be there to clarify or rectify your doubts. Thank you very much. The question should be very brief, very concise. From the audience, please, you can ask any doubts related to the today's topics or regarding the autistic spectrum disorder. Please go ahead.
Dr. Jagadish, can I bring it up?
Yeah,
I missed
please.
most of the talk until 3:30 because I couldn't access.
Thank you.
The discussion about epigenetics, genetics cannot be linked to autism, even with microarray, other than the known genetic syndromes. And there is enough data now, the electronics and the screen time early on is disturbing the neural pathways, which is a lifetime pathway development. And there is so much of emphasis placed on nurture, face time and float time and direct one-to-one attention. And I commend the presentations. You've included everything, although it could have been elaborated on the ABA and various therapies. Everything is important. I think we should. My question is, how much are we focusing on preventing autism, 0 to 3 parenting interventions and stabilizing the environmental for survival versus thriving with the multisensory integration, because only 5 senses are there. And now autism is considered as a sensory processing disorder with the poor communication. And a lot of providers have to understand by 5 months, we have to really teach them the language. By 2 months, the native language, and they can learn multiple languages. Sensory inhibition, freezing in dissociation, freezing in hyperarousal state becomes a trait, and that is causing. And I think AAP, I don't know if it was mentioned here, ASQSE is there from birth, and we are paying attention to that now to catch it very early and to intercept and educate the parents.
Dr. Leena Srivastava, ma'am, please.
Yes. Thank you for that extensive information and questions. Of course, because of the lack of time, each and every tool, etc., could not be elaborated, but I absolutely agree with you. More and more our emphasis, and we started with that talk on early identification, because I think we all know what is autism, we know what to do, but we really need to catch them early. We want to go right from now. So I think we are running a lot of modules amongst pediatricians, amongst the public, to create awareness, to talk about the red flags, early signs, to be able to catch them as early as possible and not wait for the age of labeling. About the scales, I agree with you, even though I covered only MCHAT in the talk because we had only 20 minutes. But I agree with you, ASQ, socio-emotional, is a very good tool to pick up, very small limitations early. Also, the infant toddler checklist, the ITC, you would agree, is a very good tool to pick them up early, which starts from 6 months onwards. So I agree, ASQ, SE, and ITC are good screening tools which can be used to pick up little limitations early, but MCHAT is the recognized, screening tool that we recommend much more, because obviously it is much more easier to use. Pediatricians are coming in contact with those children during immunization, and at least we don't want that period to be lost. And as international and national recommendations go, the 18 and 24 months is MCHAT was emphasized on, but I absolutely agree with you that we must go ahead and start much before 1 year of age. We must pick up the red flags early.
How about advising on not using electronic gadgets under 30 months of age, because that is disturbing the Bayesian principles of the visual spatial
Absolutely. So if you had followed my talk, we did speak about whether or not you find a risk to the child, whether or not you are talking about autism, but any parental concerns, any concerns from the pediatrician side or from any side, you have to give the parent anticipatory guidance, not only about screen time, but about play, about age-appropriate stimulation. And we did discuss this in the first talk of the day.
Yeah.
Thank you so much for bringing it up again. I absolutely agree with you.
Yeah, I agree with Dr. Leena. Also, we actually speak to our obstetricians to sensitize the mothers towards this ill health of the ill effects of all these gadgets, so that they are already sensitized to the thing that they shouldn't expose these children to less than 3 years to gadgets and interact with them as much as possible. So that is one other thing we do in our hospital, where we involve the obstetricians to sensitize the mothers, apart from the neonatologist and pediatricians speaking to them on the regular follow-ups to reduce the gadget time or no gadget time less than 3 years.
Absolutely.
In my observation for 6 months in India, this time, I have seen that parents easily fall into giving electronic gadgets to make a child eat, and not realizing it is because of their physiological anorexia stage from 12 months to puberty that kids don't eat, and respecting that. I think the part and parcel of the behavioral counseling should be on taking only 4 to 5 minutes each well-child visit, that the parents can understand the various stages of development, rapid transitions, and understand how to handle them through positive parenting. Although we don't want to cause it as a refrigerator syndrome, but an essential part of it is prevention is better than cure. And we have to be geniuses in preventing these developmental disorders. As I mentioned in the chat, that Stephanie Amis has done the DTI studies, and the DTI diffusion tensor imaging data is similar with the ASD as well as with the ADHD, with the OCD, which is a later after the brain networks have been established. Something happens, they get locked in a certain pattern. So, with all the data that we have to, as pediatricians, I'm here, I can join the group, we need to prevent it. And that's what I focused on for all my life.
I agree with you completely, Doctor. I think early identification and intervention is the way to go. I agree screen time is very prevalent, but I think it's not only in our country, it's all over the world. That is why anticipatory guidance about screen time should come very, very early. I like your third point as well, that even though the refrigerator mom theory has been disqualified, so we cannot actually use it as an etiology, but screen time definitely has shown us some deficits in development, not directly correlating with autism, but at least with delays in speech and language, with a lot of behavioral problems. So definitely, and agree with your fourth point completely, that in fact the guidelines specifically state that feeding time should not include screen. And so coming back to mothers talking to their children, singing to their children while bonding with them, while feeding them, is the way to go. And I think all of us pediatricians are taking a big hand in, passing this message on. And we hope that this webinar also passes this message across very clearly.
Thank you. Thank you for
Thank you so much.
Thank you.
Any other questions? Please raise the hand. Some people are asking, in which age we can start screen time to our kids? Dr. Leena.
So, yeah. So actually the guidelines say that below the age of 2 years, screen should be avoided as much as possible. Even above the age of 2 years, they specify that you may give your child 1 or 1.5 hours of screen time, but the quantity is not important. It is qualitatively, how is the screen used? And the screen time has to be used in an interactive manner. Like you're watching something and you're interacting with a child while watching it. So you are talking about, ye dekho, chota bhin kya kar raha hai? Oh, let us also jump like him. So you're interacting with the child while you're watching screen. It's not that one-way gaze screen time that most parents subject their child to. But I tell parents, if you're going to keep on interacting with the child while watching screen, why would you need the screen? Most parents use the screen as a proxy parent. If you don't, if you're going to spend quality time with your child, just do away with that screen. Why do you need that 1 hour of screen time at all? In fact, qualitatively, if you're talking to that child, that would probably stimulate the child much more. So let us not follow the guidelines to the T and say, oh, 1 hour is allowed, I'm going to give the child 1 hour. Avoid screen time as much as possible, and please avoid screen addiction, because it is going in a big way in very, very young toddlers. For older children, so I don't even want to touch that topic today. I think Dr. Lokesh will agree, and Dr. Jagadish.
Absolutely, absolutely.
Dr. Lokesh, sir, please add a few for this from your side.
Yeah, I think already Dr. Leena has covered that aspect of it. I think it should start from very early age, even before, if the mothers are sensitized from the beginning.
I agree.
We actually are trying to put up banners in the antenatal units, saying that how to give positive stimulating environment for the children who are going to be born. So with that, I think even before they are born, the mothers are thinking about it. So I think it's much easier for us to inculcate those things at that stage is what we are trying to do as an exercise. We are putting up standees in the obstetric units. So that actually helps in the, we cannot assess the impact of it, but I think it's a positive way to go about is what I feel.
Absolutely. I think that's a great step, because family screen habits boil down to the children, right?
Can I add something to that one? Because unfortunately from Wuhan, a study has come by Zhou, Lin and Yin, who documented frontal lobe attrition that rapidly happens with 3 hours of screen time and electronic gaming. The disengaging electronics is unnecessary. And if it is required for your engaging electronics, to complete a project for an older age group, but as long as the social emotional learning has had its basis and roots, which is underlying factor for cognitive flexibility, cognitive intellectual development, and emotional self-regulation, that happens 0 to 5 years. So the electronics, as Leena has said, that it should be curbed. And at a later age, 3 hours a week is causing attrition, lack of motivation, ADHD to 40 neuropsychiatric conditions. We need to stop the electronics as a means of engaging children. We need to enhance the family time and one-to-one communication. Yoga is good, music is good, learning musical instrument is good. We need to educate the whole society again. Post-corona era, I think it's the right time to do it.
So, Dr. Jagadish, you have another idea for the next webinar, which probably should go on promoting positive parenting and child development.
Jagadish.
Yes, sir. Dr. Om, sir, I want your contribution for the same question, because you are from psychiatrist background. Please.
Yeah, I think it's very well covered by Dr. Lokesh and Dr. Leena. And there is one question which I could see in that chat box.
Yeah, please.
Parents having mental illness or behavioral disorders cause autism. Time and again we have been talking about this, and let's make it very clear that as of today we don't have any exact cause known for autism, and whatever we know is that it is a sort of a biological in nature. Maybe we have some genetic causes which we may have to identify in near future. So therefore, let us not identify such kind of factors such as parents having mental illness or any other psychiatric disorders or behavioral disorders can cause. No, it cannot. But what is important to note here is there is a family where there is a positive history of psychiatric illness in the family to that of a family which doesn't have any psychiatric illness. So there is a likelihood that there will be impact on progress which is seen in the child in the family where there is a positive mental illness. So therefore, what is important to note is that how to involve in training the child. Ultimately, the training the child and helping the child is important rather than trying to find out exact cause, which may take a little longer time.
Doctor, in USA, there is a major concern about postpartum depression in the mother and poor interaction for the multisensory integration. So there has been, we give depression skills to the parents and they have to fill them out, and we need to take care of the parent immediate postpartum time, and that has been a major concern. Schizophrenic mothers or parents have children with autism also. That some of the studies I read. So apart from all of this, making the parents nurture every brain cell 0 to 3 seems to be the focus by Eric Chesney, who documented overstimulation of the neural pathways until 2 years and activation only after 6 years. So TTIs are proving that. So a focused target cause and cue oriented Bayesian principle application for the mini columns and macro aggregates seems to be the way to go. And we need all the IAP to take a major role in preventing autism or ADHD or any other developmental disorders.
I think just a
True.
last
But
question.
I think
Susan has asked a question to differentiate between autoimmune diseases like pediatric autoimmune neurological disorders secondary to streptococcal infection and Lyme's disease. So usually the PANS comes with spectrum of movement abnormalities as a flurry of sudden onset movement abnormalities, and along with some speech regression might be part of it. But it is never just the speech regression in PANS. So you will have some motor tics which comes on in a flurry, or you have some dystonias or chorias which comes on with this. And it is that sudden onset, and you do the testing for your streptococcal infection, you get positivity. But something which is very insidious onset, slowly these symptoms are accumulating, that's usually not PANS, what you are talking of. Lyme's disease is much more easier because they come with symptoms of meningitis, some facial weakness, and you have easy testing to confirmatively diagnose Lyme's disease, and you can treat it with the 14 days of ceftriaxone. That should help. PANS in US, actually there is a lot of overlays, and people tend to actually try and see whether there is a treatment for some of these autistic features. So we have had children coming back from US where they were diagnosed as PANS, given IVIG and other immunomodulations. But some of them had PANS, but many of them had a typical regressive autism. So I think that's where, but clinically as a neurologist, we should be able to make a distinction easily based on the presentation, and there are supportive tests. Hope that helps.
Dr. Leena, madam,
yes.
please highlight about the difference between stagnation and regression, because most of the pediatricians do get confused with these two, aspects. What is regression? What is stagnation?
So I wonder if Dr. Lokesh would like to, throw light on this. Yeah.
So stagnation is you have stopped acquiring any new milestones from a point, like you have started walking, you don't start running. So that is stagnation. Whereas you have started walking, then you lose walking. That is regression.
I would also like to clarify that even in the first talk, though we mentioned regression, what I didn't mention that time due to shortage of time was that if you go back on the history, most of these children will have a delay even initially. The regression is only what brings the parents to our notice, they notice that something is wrong. So most of the children would have had a delay even before that, before the phase of regression. So, Dr. Jagadish, are you able to get all the 5 of us on one frame, or it's not possible?
Yeah, I'm taking a snapshot. Okay, everybody in screen. Yes. Okay, done.
Thank you so much.
Thank you.
Pleasure interacting with everybody. Thank you so much.
And I want to thank individual. I want to thank Dr. Leena ma'am, Dr. Om Sai Ramesh sir, and Dr. Lokesh Lingappa sir. Really thankful a lot. Because
thank you, Jagadish. Thank you, Jagadish.
Thank you so much, Dr. Jagadish, for bringing us together.
Guiding me like anything. So finally, this is the thing happened.
Thank you.
Yeah, no problem. I am trying to share.
Yeah, sure. Make sure that comes on YouTube so that it will be helpful for the families. Yeah.
Sure, sir. Thank you very much.
Bye, everybody. Thank you so much. Bye-bye.
Thank you.
Now, I am going to introduce one of the organization, namely Nayi Disha. They developed a web-enabled and mobile-accessible service platform in collaboration with various stakeholders. It is a knowledge hub, that is information resources with the latest evidence-based information available in an interactive and easily accessible format. 375 articles in English, Hindi, and Telugu. The parents and therapists can find the services which are multidisciplinary in the field of neurodevelopmental disabilities. And it is very useful resource platform to the parents also to identify or to locate a therapist or a doctor on this platform. So please have a look at once to this video. Thank you.
Welcome to Naidisha. Naidisha is an online portal with information resources related to intellectual and developmental disabilities. Our aim is to support families with their information needs so that they can provide better care to their loved ones. The web portal hosts a service directory, a knowledge hub, and a list of upcoming events. The online parent communities are currently hosted on WhatsApp. The service directory provides a list of professionals and organizations that provide any kind of service for children or young adults with special needs. Let us see how it works. If I am to find therapy centers in Hyderabad, I will first select Hyderabad as my location and narrow my search based on the provider type therapy centers. Here I can see a list of therapy centers, including parent reviews in some cases. I can also filter by whether the provider does home visits and based on different disability conditions, locations, and age group. The user can obtain all the details of the service provider, including the phone number and the email address. This directory is constantly updated by our team. If you are a provider and want to be added as a service provider with Naidisha, please click on Register as a provider. If you want to suggest a provider to be added to the directory, please click on Suggest a provider. The Knowledge Hub contains hundreds of articles created in collaboration with eminent professionals in their respective fields. There are articles related to multiple subjects, including early childhood, developmental disabilities, getting a diagnosis, transitioning to adolescence, therapy management, future planning, and there are subtopics within each. You can also select articles based on whether it is an audio, video, or an FAQ list. You can also search by typing in the keyword. You can find inspirational blogs and experiences shared by many parents in our community. Please sign up on the website and register as a parent to receive regular newsletters on various topics. Do not forget to check our website for upcoming workshops, parent support meets, and register if you would like to attend. Our team works hard and continues to add new articles every week. So keep visiting and learn more. Be informed, be connected, and be empowered. We are working on improving your experience of using Naidisha on mobile as well. So stay tuned. Thank you and happy parenting.
Thank you, panelists and participants, for the wonderful evidence-based discussion. I would like to extend my heartfelt thankfulness to all the speakers individually. Dr. Leena Srivastava for her topic on early identification of autism, surveillance, and screening in clinical practice. Dr. Om Sai Ramesh for his topic on depression in adolescents with autism. Dr. Lokesh Lingappa for his topic on role of genetics in autism. Mr.Govardanachary Vadla for his topic on differential diagnosis of autism and interventions, speech language pathologist perspective. Last but not least, the audience and my students for making this webinar as a successful event on this day with enthusiastic participation, with a tremendous response, with the over exceeding enrollment. I would also like to extend my thankfulness to my team Mrs. Monisha, Mr. Ravindra, Mr. Naveen Kumar behind the screen for making this event successful. And I also like to add my thankfulness for the support and encouragement from Almighty God, my parents, my guru, and my well-wisher, Professor Dr. P. Sudarshan Reddy, a veteran pediatrician, and my friends and my family, and also my well-wishers. I appreciate all of you for your time and energy spared for this webinar. We welcome your valuable comments and suggestions, if any. Feel free to contact me on my number or through email, which is displayed. If any inconvenience occurred due to a technical error, kindly regret in this regard. Thank you one and all. Namaste. May God bless you all. Have a nice day. Thank you.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं